was great.
Assalamu alaikum wa rahmatullah. I would like to thank you again for staying around with us and joining us in EPOMEC 2019. Just a few housekeeping notes, if you don't mind. The live surgery will start immediately after this symposium, and it will be coming from Egypt, Cairo. It's a combination of a very, very challenging cases that I'm sure that you will enjoy it if you stay around with us. The second housekeeping notes, don't forget the Best Attendance Award, and this will be 2 tickets to fly to Paris to attend the ESCRS. So if you continue, just make sure that you're scanned properly, so possibly you'll be one of the winners. We'll announce it at the end of the day. Now you can put my presentation if you don't mind. My name is Saleh Masabi, and I would like to welcome my co-moderators and my colleagues and speakers, Dr. Muhammad Ali Hisham and Dr. Walid Ghubashi. In my point of view, the session that we will go through it now is possibly one of the things that every single one of us will be using it for the next maybe 5 to 10 years. Over the time, we see so many technologies. We see so many products come to the conferences, just like the EPOMEC or other conferences. But if you think with me, my colleagues, some of them, they really stay, and some of them, they leave. This product that we will discuss tonight, definitely, I have all the trust that it will continue, and it will be the golden standard for all of us. The question will be, well, I'm showing my financial disclosure here. I'm a consultant to Alcon, but I will tell you where the point is coming from. Can you start the presentation? Okay, it's here. Beautiful. Let's agree on this concept. Trust takes years and years to build. Do you agree on that? This is a reality that we all know and we all live through. And the reason why I have the full trust that this product will continue and it will be the golden standard for all of us is because of this history. 1994 was the time the AcriSoft was launched. 25 years ago. How many so far have been implanted? If you see the last or the end of the slide, more than 100 million IOL of AcrySoft platform have been implanted worldwide. What's the implant number one in the US? This is a question for everybody. Do you know what's the most common implant in our body? It's the IOLs. And the second for us, and the second far for us, is the ear implant. So last year, 2.5 million IOLs from all platforms have been implanted in the US versus 700,000 of the ear implant. So we have the number one worldwide implant for the IOLs as a product inside the body. And we all know that Alcon is taking the lead in that part. However, the history here that in 25 years and over 100 million implant was already done. And every single person in this room is already, or is still already, continuing to use this kind of platform. And from that, I think the chances are very strong for us, and I have the full trust that we will have an excellent platform because they use the old and the best of the old technology, and they enhance it even further, and they added extra technology. We already were happier with the other one, but now I should expect that we'll be happier than even in the past. I will not go into the details. My role here is to do the introduction, and maybe I'll just show you a video. But I said it's the best of both worlds. Why is the best of both worlds? Because in this new product, the Clarion Autonomy, it's a Clarion because of the clarity of the vision and the new material. So it's a new material that I believe Dr. Mohammed will be covering. And it's an autonomy because this is the first time we have automated IOL injector. And we'll explain the concept why it's an automated. So I'm going to show you a video for 2 minutes, and then my colleagues will carry on to explain it in details. So this is the, I think I run it from here, or you will run it. Can you run it? Yes, beautiful. So this is the nozzle. The nozzle is 3 millimeter, if you see it here, at the edge. And this is the barrel. If you can stop here. Stop. Okay. Sorry, I should have been, maybe I can do it from here. Do I have a control? Oh, I have a control here. Okay, so if I stop here, this is the nozzle, and this is the part will be going inside the anterior chamber. It's about 3 millimeters, and that allows you to go through the incision and possibly minimizing as well the stretching on the corneal incision. The part which is posterior to it, this is the cartridge, just like the standard we are using. This is the nozzle where you, the opening for putting the viscoelastic. And if you realize, it comes like a funnel. Tomorrow I'll explain to you why. Keep it in your mind. It's very interesting. Now the part we are seeing here is the locker. So you have to remove it first to work. This is the Clarion IOL as a product for us. Now I'm putting the viscoelastic inside this funnel shape to fill the viscoelastic all the way till the edge. That's the only part I'm doing. You don't need to use the nurse for this part anymore. Nowadays, everybody will be implanting himself and loading the lens himself for every surgeon, presbyope or not. Now we need to take the locker out, which is this part. So you pull up and to the right, angle of 45 degrees. It's very straightforward. Now you press on the lever for the IOL, the one on the right, but doesn't show here. I'm sorry for that. And immediately you'll hear a click, and the click is moved and controlled because of the plunger pushed, and will be pushing the IOL, and you have a full control with your finger to go speed 3 millimeter in a second, or to stop immediately. It's like a foot pedal in a car. And the implantation is like really straightforward. There is nothing different. But as you see here, I don't need to use my second hand. And the nozzle itself is like can fit within 2.2. This is case number 2 possibly for me. So, and it still is like, honestly, I think it's straightforward. There's no learning curve. Possibly one case you do it on the wet lab, and then you can carry on with the case. So I think that's enough for me, and I'm going to welcome my colleague, Dr. Walid, I guess now. So Dr. Walid will take it from here. Thank you.
Hello, it's nice to chance to present this new technology. So what's different about Clarion? This is two issues here. First is the way of delivery. The delivery, as mentioned by Dr. Saleh, is automated in the first time. We have been looking for this kind of automated delivery for a long time, and it's already preloaded. And also the manufacturer of, the way they manufacture the lens itself, and this will be explained in more details with Dr. Muhammad. So what about it? It's a single use, definitely it's not reusable, disposable. And the overall diameter and size and weight is making it very easy to use for all kind of surgeons. So it's not requiring a big hand. It's very ergometric, so it's you can just hold it anyway. And it's not too heavy. It's still also steady for the surgeon to use. If you just look to this part, this is a, okay. This projector. Okay, thank you. It's not working. I'll just do with the mouse here. So this is the internal structure of this injector. So here, this is the whole thing is about this part. It's the gas canister. It includes carbon dioxide, and it's more in fluid form. And then when you press on this lever, this start to the whole action, and the release will start, and the pressure will increase in this canister, pushing the whole system forward. The autonomy ergonomic design support very easy use, and it's also go through a very small 2.2 millimeter, so you don't have to change the way you construct your wounds, and still is stretchable, which is something advantageous. So here's the canister, and this is the central part of the autonomy, and this is the lever. The lever is very easy to use, and it is adjusting the speed you are going through the eye. So the maximum speed allowed is 3 millimeters per second, but still you can stop just by releasing your finger from this lever. You can increase the speed to the maximum whenever you need to do so. And this part is the part responsible for the assembly. So this blue part in the front, you can just use it as a filling device for the viscoelastic. As mentioned by Dr. Saleh here, for this nozzle, you can just put the viscoelastic, and then you just make the whole instrument ready to be used by just removing this part. And it's very easy to be removed, just like mentioned by Dr. Saleh, just you have to go up 90 degrees and just go out. So it's really easy to be used. And then whenever you use this, so whenever you just remove this security part here, you see this part of the anterior part of the nozzle, which is already including the IOL itself. So you need to inspect the IOL presence, and if you are make sure that it's fine, so just you just need to also check the nozzle here. The nozzle here is have a stopper, and this stopper make the whole instrument safe, so you cannot go inside the anterior chamber more than you need to do. And still the nozzle inside is 3 millimeters. And if you are familiar enough with the previous preloaded system, the short nozzle was a problem, because without 3 millimeter nozzle, you just stop with the IOL at the entrance of the anterior chamber. And you need a lot of manipulation later on just to put in the bag. But with this 3 millimeter nozzle, you just make sure that the IOL in the bag from the first click. So after you finish filling the OVD and then removing the blue part, you just need to click it. You can click Either way, if you with your thumb, you can do it with your thumb, or you can use it with your index finger. It's almost the same. When you hear this voice, so now you have already started the procedure for you. Right? You have 1 minute to go and put this nozzle inside the wound and just try to click again. When you click again, the IOL will move, start moving. And it is very precise. So you move and you can stop it and look to the IOL, make sure that the trailing haptic and leading haptic are in the proper position. And you can move again until you see the edge of the IOL now is coming out. And then you have inside the anterior chamber, you just complete the pressing on this lever, and you will find the IOL and going inside and unfolding inside the bag. So this is the 3 positions you can just find to make sure that you are in a safe way. So yeah, this is fully tucked trailing haptic or partially tucked trailing haptic or looped trailing haptic. All this is fine to proceed with. So this is a fully tucked leading haptic here, and also untucked, loosely open leading haptic. Still, this allow a large safety profile for the whole device. And if you find different position like open looped leading haptic or looped outside or straight leading haptic, you still can proceed, but you need to do some tilting of the whole device to make sure that your IOL is in the correct place from the first touch. This is a video, and I believe this unique technology is very useful if you are going to operate under topical anesthesia. So one hand now is just using to implant the IOL, the other hand can stabilize the eye of your patient. You don't have to be so fast in doing this or instructing the patient to look downward or so. So this video, this is a canister, innovative carbon dioxide power, and this is a preloaded IOL, Clarion, and Dr. Mohammed will tell a lot about these characters of this new and unique IOL. And this is the step operation. You can also depend upon your assistant to fill the viscoelastic in the proper position, and then just remove this plastic part and then do the click. And as I mentioned before, you can do it with your thumb or use index fingers. It both goes well. And then keep injecting until you see the IOL folding, and then stop when you reach this step at just before the nozzle. Now you just check. You still have 1 minute to go. There's no problem, no need to be hurry. And then now just put the nozzle inside the anterior chamber. Go first here. Okay. Now if your right hand the surgeon or whatever, so your other hand now is free to stabilize the eye, and with the nozzle inside, just start again to press on the lever. It will go inside smoothly, and also it will unfold. So still, this is very good about this is very sensitive. So you just can change your speed whenever you want, and now you just implant the IOL. And this is very unique about this system. It's easy, intuitive, and full control. Thank you.
Good evening now. I just want to discuss with you actually some of our goals. We didn't have yet our perfect monofocal IOL. And if you think that the monofocal is the easier multifocal or easier IOL than multifocal, and it has no problem for all the patients, and some even doctors don't like multifocals because they have their problem. I think monofocal doesn't have any problem. Actually, no, we have lots of problem with the monofocal. We have of course, the posterior capsular opacification. We have the IL decentration. We have the positive dysphotopsia, you know, and we have this problem actually is a big problem, and myself, I have at least 3 to 5 patients every month that come with a shadows. They see in shadow at night, and they keep on like that. Some people improve within a month, and some people just keep on like that for a longer time. So this is a really big problem, even the monofocal. IOL decentration, the IOL glare, of course, if the lens is not that clear, you can have this catastrophic vision at night. The tilt can give us lots of astigmatism, unintended astigmatism, if the lens is not that stable in the bag. The effective lens position, if the lens is not in the intended position, if it's moved forward or backward, it gives us some hypermetropic or myopic shift of the lens. This is all what we know. So we need actually a lens that can stay in the position that we need it to stay on. So do you notice any change actually in these two lenses? Any change in the shape? So it looks similar actually, but not everything similar things are identical. There are lots of changes in these lenses. Usually they want to discuss it as optics of the lens, mechanics of the lens, and material of the lens. The optics and the material has changed lots since the IQ lens. And this is why we think that Alcon actually is brave. Instead of just getting one innovation for the injection, it gives 2 innovations in one lens, changing the mechanism of the injection and changing the lens itself. So the same parameters are the same between the IQ and the Clarion. Same thickness, same everything, same platform actually. It uses the whole 6 millimeter of the lens, unlike the other kind of lenses like thickness. They have a ring around the lens that sometimes I thought this is actually a smaller one. The UV protection of the material is very high, so nearly 100% of the UV light is abolished. And the innovation of the design, this is the most important thing in this lens. It reduced lots of positive photopsia, and this is why, because of this edge of the lens. Oh, sorry. Because of the edge of the lens. So I'll go back to it. I will just point from here. The edge of the lens. When we have not direct light, just side light, the light transmits through the lens in 3 ways. The one in the middle just transmits regularly to the retina, focused on the retina. But the one on the edge here, there are lights that reflected on this edge inward, we call it reflected glare, and the one that are transmitted, and we call it transmitted glare. And this is why we have the photopsia, this positive photopsia. So the Clarion came up with the slightly curved edge. And this curved edge made the reflective glare much less. It's not abolished fully, but it's much less than the regular straight square edge, which gives very high, especially in mesopic conditions, very high positive photopsia. The other lens that has the peripheral ring, they made it specially to abolish this positive photopsia, but actually it increased the transmitted glare. The mechanics of the lens, it's the same platform of the IQ. Nothing's changed there. Diameter is the same. Stability we know that the stability of this lens is very stable. It's self-centered, nearly self-centered. We know that it cannot rotate, or the rotation is very minimal, and that's why we trust the toric IOL with this platform, because if we put it on one axis, most probably will not have more than 1 or 2 degrees rotation. The square edge by itself, this sharp edge here, made the PCO much less than the other platforms. So it's just like the IQ, and it's actually the PCO is comparable, like IQ. It's less than IQ, but it's comparable to the IQ. So, and it's in the studies showed that the Clarion versus the accuracy of the PCO, the YAG capsulotomy, was decreased in 1 year from 1.5, from 2.2 to 1.5. The material is another story. The material they made it as clear as possible. It's clearly, if you compare, I show pictures of the other microscopic pictures of the other lenses and this lens, and you can see it's fully clear. And they have improved the glistening of the lens. This is one of the problems, especially for ladies, of the glistening of the lens. The glistening usually happens when there are vacuoles inside the material of the lens, and then these vacuoles will be filled with water or fluid, and then it will reflect the light when you see it on the street lamp. So they have made something that I think they are the secret, and the clarity of the lens itself has improved lots. And if you think that these items are not that important, I have these two cases from the literature. This is a case of a 75-year-old lady who was complaining of hazy vision, especially in dim light, and she said, I can't see anything at dusk or after sunset. And IOL they examined it, was centered, and they found out this picture of micro vacuoles inside the material of the lens. It was more in the right eye than the left eye, but it was actually in both eyes, and this is why this patient complained. She gave history of consulting four ophthalmologists. She went to 4 ophthalmologists, and neither one of them cared to look at the lens material itself. They looked at maybe everything else except it, and even one suggested that she may have to have LASIK or corrective surgery for the residual ametropia that she has. And she went to the doctor that it was on the first page, and he changed the lens, and it was actually, they found out that this was the problem, and the patient stopped complaining. The other one is the opacification. We see all the lens opacification once or twice in our life, and this is a case of 60-year-old woman who had who went to local ophthalmologist. He did cataract, but after 2 years, she complained of reduction of the vision, and he diagnosed her as PCO and did YAG for her. She didn't improve. She went to another ophthalmologist, and then he referred this ophthalmologist, didn't know what's it, so he referred her to a neurologist, and then the neurologist did MRI and CT scan, and they didn't know the problem. But actually, she went to another doctor in New York, and he found out that this lens was opacified, and removing the opacified lens solved the problem. So she went to a lot of neurologists and everything, but diagnosing the problem. So this shows how important to have a clear lens and how important to have glistening-free lens, or at least less glistening from the lens. Thank you very much.
Thank you, Dr. Mohammed. I think this was a very good introduction for the concept, if you want to use the mic as well, of the autonomy and the material. So where do we start? We start from the material? Yeah. Okay. Sure. So how do you find the reports of, or what's the added thing in terms of the material itself compared to the accuracy of? What's the new things?
The clarity of the lens. If you compare both of them, they increase actually clarity, the subsurface clarity, they increased a lot. It's very clear right now. And the vacuoles, the glistening, all of us know how the glistening can happen to a patient and how they complain actually psychologically and cosmetically, the glistening. So they reduce.
And what about the glare? The glare, because this is the thing that you really, the glare, how do you find it? What's the report there? What's happening with the design in terms to avoid the glare?
They changed, they made it clear. I asked them how. It's a secret.
It's a patented. It's a patency for them.
Yeah,
it's not the standard curvature.
Yeah.
There's a new design just for them. That's its appropriate. It's patented for Alcon.
I think the design is the same. It's the material itself has been changed.
No, and even the edge. The edge and the curvature
of
the edge, yes.
The edge, but it's by convex aspheric surfaces the same, but the edge, yes, we explained that the edge has been changed, and that's why, and this is why the positive photopsia, which I suffer actually from my patients.
Well, every one of us will always suffer from the glare because it's an IOL, and there is always an edge, no matter what's the plan. However, the idea is to reduce it as much as possible.
Yeah.
But I think this is one of the most important things that they came up with, the material and the curvature. But autonomy is a new game. It's a new game. First of all, just in terms of introduction, do you need to use a specific viscoelastic or water, or what do you need to use to fill inside the injector?
Yes, so far the only tested OVDs to be used with the autonomy is the one approved by Alcon.
Okay.
So but you can use any type of them. You can use the ProVesc,
2 minutes.
The Viscoat or the ProVesc, any type of Alcon approved OVDs can be used safely with
cohesive
autonomy.
or dispersive.
Okay.
So we can both of them, cohesive or dispersive, as long as they are approved by Alcon in the primary tests for the whole device.
Do you need to change the technique for the implantation?
I think it's really valuable if you are going to do your surgery on topical anesthesia.
Come again, sorry?
On topical anesthesia.
No, I mean the technique of implantation, whether wound assisted or through the wound. Do you need to change for any surgery?
No need for a change.
So
you
you
just
can
adopt the same technique used to use during the Monarch injector, or if you are using the Ultracert. There's not much difference in the technique or position of your hands, or you need to adopt a new sitting position. Nothing.
So no change in the technique.
No.
Well,
Actually, I heard that they can be introduced, especially in low powers, to a 2 millimeter, not 2.2, to 2 millimeters. Above 25, you have to make it 2.5, 2.2. But otherwise, you can
go through the.
So most probably they increase the nozzle of the.
I think the advantage also the nozzle. The nozzle now is a little bit longer than the one we have in Ultracert.
Yes.
So I think the less popularity of Ultracert came from that you're less controlling what's going inside the anterior chamber.
Yeah.
But with the new technology with autonomy, you are in control in a steady speed, a controllable speed, even until you are inside the bag. So actually, maybe you don't need to go and do the rotation in a very precise way like you do in Ultracert.
Beautiful. Well, actually, we have so many questions that we can raise, but since the live surgery is ready, so I would like to introduce, thank you, Dr. Mohammed, and thank you, Dr. Walid. We would like to introduce the second panel for the live surgery, and if we can open the satellite now. Thank you, doctors. Shukran. Shukran, doctor. We'll go to the other side. Okay. So just as an introduction for everybody here, this is Al-Watany Hospital. I'm not sure if you are running video there. Okay, but cannot hear.
كده الباناليست بتوع اللايف سيرجري هناك ظهروا على الستيج.
سوري ايه ريمون؟
الباناليست بتوع اللايف سيرجري من هناك هم كده طلعوا على الستيج.
اوكي.
Good evening, dear colleagues. Good evening, Dr. Salah Musabi and your esteemed guests.
Good evening, Dr. Fathi, Dr.
Can you hear me?
Yes, dear. I have here a panel with me, Professor Hassan Murtada from Egypt.
Thank you, Dr. Salah, for inviting us again to participate in your popular meeting of EPOMEC. We're really proud to be invited for the second year in a row by broadcasting live surgery from Al-Watany Eye Hospital in Cairo, Egypt. This live surgery session will be moderated by Professor Dr. Abdullah Hassouna, Professor of Ophthalmology in Ain Shams University, and the Chairman of ARVO Egypt, and the board member of Al-Watany Eye Hospital, and also will be moderated by Dr. Amr Al-Awamri, Assistant Professor of Ophthalmology in Ain Shams University, and one of our esteemed surgeons here in Al-Watany Eye Hospital, and by myself. You know that everybody is very keen to participate in this very important event. So the lineup of surgeons this evening is totally different from the lineup of players in the last year. As Dr. Musabi requested, most of the cases, if not all of them, are tough and challenging cases. They are still not uncommon cases that we face regularly in our practice. So the surgeons in the order of appearance will be Nader Fauzi. I'm doing suture keratoplasty. Dr. Asaf is doing a case of dense cataract with an inferior iris coloboma and defective zonules. Dr. Muhammad Abdel Hafiz will show his art in blepharoplasty in unilateral cases. Dr. Ahmed Yusr Al-Armouti, our glaucoma surgeon, is doing the least invasive, the mixed glaucoma surgery. Dr. Basim Faiz is doing a tough brown cataract in the shallow anterior chamber. Dr. Ashraf Armea will be managing a case of white cataract. So we have all types of colors of cataract tonight. Dr. Magid Mikhail is showing us how to do vitrectomy in an OCT assisted in a case of full thickness macular hole. Last but not least, Dr. Rami Riyad is showing us a case of Yamani technique in intrascleral fixation in rehabilitating a case of aphakia. I don't want to waste the time. Please, Dr. Amr Al-Amri, go ahead and present the first surgeon.
Assisted sutureless keratoplasty is going to be performed by one of the most talented surgeons, Dr. Nader Fauzi. Dr. Nader is a consultant of ophthalmology at Al-Watany Eye Hospital and fellow of Zentrum Cologne, Germany. Our patient today is a 23 years old male patient that came complaining of poor vision in his left eye. Examination showed a superficial corneal opacity that was found to extend as deep as 184 microns, as evidenced by the anterior segment OCT, with the pentacam showing a central astigmatic island. Dr. Nader, let us proceed.
I am very happy to share with you this technique today. What we're going to do is we're going to remove only the tissue from the cornea that is diseased. We have a very superficial stromal opacity, but still not as superficial as it could be removed by a regular means of PTK. So we want to actually remove this anterior lamella. And I believe now in the femtolaser picture, you can see clearly this opacity that is bisecting the pupil exactly in the visual axis. Wonderful. Laser. And what we want to do today is just remove the diseased tissue. So you are making a very thin, flap-like cut in this host cornea to remove about 200 microns just beneath the level of the anterior stroma, respecting the rules of refractive surgery in terms of corneal stability and residual stroma. And as you see, we have just completed this cut, and we are going to be coming back again to show you the same cut that we're going to do in the graft cornea. Okay, so for now, we're actually good to go, and I give you back to Dr. Amr Al-Amri.
We have now finished the host cut, and we will return later to the graft cut. Thank you, Dr. Nader. Now we'll move to the second operation, and I'm handing over to Professor Dr. Abdullah Hassouna.
So now we will start with an eminent surgeon, Dr. Ahmed Assaf, MD, PhD, and Fellow of the Royal College of Edinburgh. He's Professor of Ophthalmology at Ain Shams University, Fellow of the Royal College of Surgeons, and Consultant of Cornea and Refractive Surgery at Al-Watany Eye Hospital. His case is a hard cataract with zonulisis, a patient with 83-year-old male patient complaining of poor vision in the left eye, with a history of right cataract extraction surgery 7 months ago. His best corrected visual acuity in this eye is hand motion. You can see now a picture of the case with showing the iris coloboma and nuclear cataract grade 4 and possible IFIS. This is a UBM picture showing the possible zonulosis. And last is the specular microscopy of the case, showing a good number of cells and a CCT of 545. So we start. Professor Dr. Ahmed Assaf, please.
Okay, thank you very much. Hello, everybody. Happy Valentine. This is my gift from the Al-Watany Eye Hospital, in this case, in the Valentine Day. So this is a very complex case. I will start doing the main incision. It should be single straightforward incision, single plane. And then in this complex case, I'm expecting zonular weakness because of the coloboma, and it was evident by the UBM. So we'll do multiple paracentesis, and again, this patient is on alpha blocker. Probably he's an IFIS patient, so just prepare for the iris hooks when necessary. So this is another paracentesis here, just for the capsular support system, just to support the capsule. Now start staining of the capsule. We've got pretty hard cataract. There is no red reflex at all, so just start staining. This is air injection. I'm trying to evacuate the aqueous from the inside the anterior chamber. Now this is the stain, milking of the, just dropping the stain on the anterior capsule like this. Okay. As you can see, I'm using the paracentesis. I don't use the main incision for this maneuver, because it's just lamellar incision and self-sealed incision. Now we are ready, I think, for the rexes. I will wash now the excess stain, and we'll proceed for the phaco. For rexes formation, this is the next step. This is viscoat. This is 83 years old patient, so I'm expecting the corneal endothelium, although the number is okay, but the endothelial cells might be compromised. This is soft shell technique. This is Provisc here. Okay, now we can start. The cornea is not very good. There is shagreen corneal opacity, so that's why I'm using stain here. You can see those stria. You can see those stria. It's difficult even to puncture now the anterior capsule. This denotes the zonular lysis, quite similar to the case that I have presented by movie this afternoon. So we'll start the rexes, very gentle, very slow rexes. The issue here is we have to get a central rexes of 5.5 millimeter. And the issue here again that because of the zonular lysis, you cannot expect the behavior of the anterior capsule while doing the rexes. So just pretty slow. And now we are about to finish the rexes. It's okay. Now I will just support the capsule at the area of the potential zonular lysis. So this is one of the capsular support system of McCool. Another McPherson, please. McPherson. Okay. just to reduce the stress on the anterior capsule while doing phacoemulsification. I don't want to make too much tension, just to support the capsule in the inferior quadrant in the area of the zonulisis.
So it's very wise to anticipate problems and to be ready with all the instruments
Yes.
and all the things that we can need during the operation.
Yes. Now this is a hydrodissection. Okay, it's a pretty large lens and nucleus. Now we'll start phacoemulsification. My preferred technique in this case is the quick chop technique, but I'm not sure that I will succeed to split the nucleus from the very first attempt. So we'll be patient and try to split it in several steps. Okay. Okay, no, it's not splitted so far. Okay, now it's already splitted, but it's not complete. The fracture is not complete yet. Let's give it another try here. Okay, now it's complete. The nucleus has been split into 2 halves, almost. Now this is 1 half, trying to split it into 2 quadrants. Okay, it's not complete yet. Almost, but still there is connecting isthmus. Anyhow, I'm pretty confident now with this. Now we can take this central part, the most central part. Okay, and now I'm trying to take the other quadrant here.
Now that the first quadrant is out, we can shift to another surgery.
Yes.
ده بقى ما فيهوش بنس واضح. فل بصراحة. Okay, you can see me and hear me again? Yes. Okay, because this is the interesting part of the surgery, and this is what usually puts many surgeons off from trying femtolaser assisted keratoplasty in general, and it's the assembly of the artificial anterior chamber. So what we're doing now is we have this artificial chamber here and the cornea, and we have it filled and the system filled with BSS. What we're going to do, it's very important not to have any air inside this artificial chamber. Let me remove this to the side. Can you see the picture quite? Can you see the picture well? Dr. Ramon, can you see the picture well? Can you see the picture for good?
Dr. Ramon, can you see what Dr. Nader doing?
I'm not sure if you hear us from UAE, but we cannot see it clear.
Okay, what about, Dr. Nader, what about the sizing of the graft? What do you depend on
a very interesting question,
when you decide for the sizing?
When we take the graft, we usually have a shrunken tissue. And if we take the same size, this graft is going to be much smaller than the bed we are trying to place it in afterwards. So we do a little oversizing, not too much. What I do routinely now is I take 0.1 millimeters more in the graft in diameter than I do in the host. Yes? Of course.
Now it's good?
Yeah, we can see clear.
Yes, and this 0.1 is standard in all your cases, Dr. Nader, or you may change it?
Not for deep anterior lamellar or penetrating surgery. There I usually go a quarter higher. But in this case, this is more of a flap surgery. And when you're doing a flap in a cornea, you're cutting the same cut for the flap and the bed. You're not doing 2 different cuts. But in this case, because it's a graft and we have donor tissue and not the actual human tissue we're cutting in, That's why I do a little bit of oversizing.
Okay.
So we're putting it on the artificial chamber now, very keen not to have any air. And I like to tilt, as my assistant here is pushing the BSS in, I like to tilt it a little bit so that the air can escape from the top, which is being at the side at this point. So now I have the cornea nicely settled, nicely centered on the artificial chamber, filled with BSS, with slight pressure on the BSS there. And now I'm going to push the cover on, always pushing a little bit more BSS as we go, not to flatten it. And then this screw comes on top to screw it in place without any pressure on the endothelium. Because sometimes in these grafts, you know, if a nice anterior lamellar surgery is successful, you want to use the rest of the graft for maybe a DMEC or a DSEC. So, and then we check the pressure of the eye, it's very good. And we can proceed now to the laser to do the rest of the treatment.
When you do the docking in the artificial anterior chamber, do you experience any difficulty?
Well, it is sometimes, of course, difficult to dock because you don't have landmarks for the centration. So what I routinely do is, and I'm going to do it now, I put a small mark in the center of the cornea. Marker?
Mm-hmm.
Because this helps me on the laser afterwards to put the incisions I want to make centrally. Although this one is nice and central. Okay. And again, it's basically the same like what you do with a regular patient, only they are usually much more cooperative, the grafts.
And also the same energy parameters as before?
Slightly higher. Now you can see this is the exact same cut like we did on the recipient cornea. Also the 200 micrometers, the same side angle cut. The only difference is the graft size, which is slightly bigger in this graft than it is in the host cornea. Okay, so I am finished here. We should be meeting shortly again to transfer this graft into the host.
Okay, thank you, Dr. Nader. Thank you, Dr. Nader. We are now returning to the Professor Dr. Abdullah Hassouna and continue with the phaco operation done by Professor Dr. Assaf.
Can you explain to us what happened during the last 5 minutes?
Okay, it was a pretty hard cataract, but everything went just fine. So I'm just removing now the capsular hook system here.
I can see that the CDE is less than 20, which is good in this 5+ cataract.
Yes, exactly. Sometimes it's removal of these hooks maybe tricky, a little bit tricky, but sometimes it's okay. So we can just here like this. And still some cortex now in the subincisional area, irrigation aspiration. I will just remove it from the paracentesis that I've already made for the hook.
Do you think it needs a capsule tension ring or
no, I don't think it's needs capsule tension ring, but I will just implant the lens, 3-piece lens. This is my preference in such cases. Some cortex here and some epinucleus, okay. Okay, so the issue here is never allow the never allow the anterior chamber to collapse while switching the instrument. You can see that the irrigation, continuous irrigation is on, and once I start injection of viscoelastic, just stop the irrigation and keep the anterior chamber inflated all the time to reduce the stress on the zonule. So I'm expecting here zonulitis here, or at least weak zonule, so there is no need for the capsule tension ring, but I will implant the 3-piece lens in the sulcus and I will make an optic capture. This is my preference in such cases. Okay. So this lens, now the incision was 2.2 millimeter incision, so I have to enlarge it a little bit because the 3-piece lens can only go through 2.8, so I think now it's okay. Okay. So another Provisc, please. And now I'll implant the lens here.
So why not in the bag fixation?
Sometimes in the bag, the lens will be tilted with the bag at the area of the zonulisis. So I will take advantage of the other intact zonule all around and to support the lens. So just I'm trying now to direct the leading haptic in the sulcus, probably maybe in the anterior chamber is okay, but never inside the bag. Wait a little bit until the lens unfolds. And now retract the plunger. We can now proceed, go ahead and implant the other haptic. Inside the anterior chamber is okay. And now try to center the lens. Now one haptic now is in the sulcus while the other haptic is still inside the anterior chamber. My plan is to keep the lens in a horizontal position, Sinisky, or dialer, my dialer. Now the lens, both haptics are inside the capsular bag, and now I'm doing the optic capture. This is one side of the optic now has been already introduced inside the bag, and this is the other haptic, the other optic. You can see now that the rexis is elliptical in shape. It attains the cat's eye appearance. It's never rounded anymore because it's already stretched by the haptics here, while the optic is inside the capsular bag. So I'm pretty happy now with the lens. It's already centered. There is no tilt whatsoever, because if I implanted the lens, there is a potential of tilt in the lens in this direction because of the zonulisis, as evident by the UBM, as you saw in the very beginning of this case. I'm doing now my call. Now we are going for the pupil.
Dr. Mosabi, you are waiting for any questions from the panel in Dubai.
Okay, beautiful. So you can hear us now?
Now, we are going now for the pupilloplasty section of the case. I'm injecting now acetylcholine, trying to bring the pupil down as much as I can.
So you are planning to close the defect in the iris?
Yes, exactly.
What type of sutures will you be using?
I'm going to use Proline 10O sutures. I'm trying now to bring the pupil as much as down as I can, because this reveals the unhidden iris tissue. And now we have to prepare now for the Prolines, stitches, micrograsper, stitching.
Can you hear us, Dr. Abdullah?
Okay.
Okay, so if you can't hear us, maybe we can talk among ourselves.
And this is the other side, trying to assess how much tissue I have. You know that the coloboma is very challenging in closure of the defect, because already we have a defect in the tissues here. It's not a traumatic mydriasis or traumatic iris. So let me aspirate this air bubble. Okay. Okay. Now, Proline. Okay, so I need a paracentesis now. Now I'm now trying to close the defects here with a Proline. You know, this is Provisc space maintainer, and probably under the leaflet of the iris, trying to elevate those leaflets here, away from the capsule, and here. Okay. Some bleeding might be expected at this stage. Okay. So my plan here is to have stitch from here to here. So probably I will do a paracentesis here. And another one here. Okay.
So you prefer a bent needle or a straight needle?
I prefer the bent needle. Wash. Okay.
This is 25 gauge?
Yeah, 28. I want to take enough iris tissue now to lead this. There is some dialysis here, but it's okay. It's okay, it's manageable. Now I'll take out this here, the cursor. Okay.
Okay. Thank you, Dr. Fathi and Dr. Abdullah. Our next case is a case of bilateral upper lid blepharoplasty going to be done by one of the brilliant surgeons, Dr. Muhammad Abdul Hafiz, consultant of ophthalmic plastic and reconstructive surgery and fellow of the American Society of Ophthalmic Plastic and Reconstructive Surgery. The patient is a 41 years old female patient asking for cosmesis. Examination showing folded skin and prolapsed orbital fat of both upper lids, normal function of levator muscle, and hence the decision was bilateral upper lid blepharoplasty. Please, Dr. Muhammad.
Thank you, Amr. I will start now giving the local anesthesia. And then I will speak about the marking. Do you want me to speak about the marking before giving the anesthesia?
Yeah, sure. I have a question.
I prefer to give the anesthesia first because I usually leave the patient a couple of minutes until I start.
Okay, I just want to make sure that Dr. Muhammad's voice is heard.
Is it okay?
Can you hear Dr. Muhammad Abdul Hafiz's voice well?
Give him marking.
Dr. Amr?
Yes?
Can you start, please?
Yeah, okay. Dr. Muhammad, please
Okay,
start.
first the markings. I usually take the markings before the surgery while the patient is sitting, not while the patient is lying down. And I recheck when the patient is lying down. The lower marker usually at the skin crease, at the intended skin crease, or the patient crease if we are not going to change it. The upper mark is usually the distance between the upper mark and the brow hair is usually the same like the remaining part, which is the lower, from the lash to the crease, or more. Some people, they say 10, 10. Some people, they do 10, 12. The most important is they should be equal. If you make the crease 9 from the lash to the crease, they should be 9 from the hair, the brow hair to the upper mark of your incision, or more, not less than that. So we don't affect the function of the lid of the closure, because we know that the orbicularis is next to the skin, and if we excise a lot here, the patient will not be able to close the eye and might complain from lack of thalamus.
Dr. Muhammad, do you usually use the pre-existing skin crease or not always?
Not always. Some people, if the patient has asymmetric crease, I have to make it symmetric, so I'm going to change it between both eyes to make it the same. Some people, they have higher crease and they want it to be lower. Some people, they have low crease and they want to make it higher. But the most important thing, you don't have to follow the patient's request, because this is medicine before being something plastic or cosmesis. You have to give your opinion. If the patient wants to be a high skin and she has a very deep sulcus, for example, you don't agree, because you are going to make her look sick or hollow or very deep sulcus. You are going to aggravate the deep sulcus and will make her to look sick after the surgery. So you don't have to follow the patient request. But I not always follow the crease. Sometimes I change it, sometimes I do the same.
Okay, and when you inject the anesthesia, do you inject with a bevel up or a bevel down position in the needle?
I will tell you now what is my technique. I injected a little, I started the injection. The bevel should be up. I bend the needle so if the patient moves, because most of the cases under local anesthesia. If it is straight like this and you're injecting like this and the patient moves, you will injure the whole lid and might cause rupture globe. But if you do the bevel up and bend the needle up in this good position and the patient will move, the needle will do double perforation and come out from the skin. Will not injure the eye and the remaining of the lid. Okay. And my plan always in the injection is immediately subcutaneous to avoid injury of the orbicularis and hematoma. But hematoma is not something you cannot avoid always. And in spite of this, you might have hematoma.
You don't need to inject any anesthesia above the tarsus itself? Do you take a tarsal suture?
If I'm going to do if I'm going to do elevator, if the condition is blepharoplasty with ptosis, so I'm going to do something in the elevator muscle. I need to suture the elevator into the tarsus. I inject below the crease. But usually my surgery in blepharoplasty between these two lines. I don't go deep in this way or this way. If I'm going to do browpexy, I have to inject anesthesia upper here in this area. But I usually give the anesthesia in the area I want only. 4x4.
Exactly how much or how would you exactly know the exact amount of skin to be removed without causing the...
I'm going to tell you in a minute. When I started, I said I do the markings while the patient is sitting, and I revise them when they lie down. When the patient is sitting, I see when the patient opens the eye how much excess skin usually the patient has. Then
Dr. Saleh, can you hear me?
Sorry, Dr. Captain?
Dr. Saleh, can you hear me?
Yes, we can hear you. There is some
great.
Some noise.
Our
I'm not
surgeon, as you've noticed, most of our cases are quite difficult, and I'm sure you would tolerate. But anything can happen in these difficult cases, and you will see how we manage them.
Beautiful. Can you hear me when I answer you, Dr. Fathi?
Our next surgeon is Dr. Ahmed Yusri Al-Armouti. He's a senior glaucoma surgeon at Moorfields Eye Hospital in London, and he's a visiting consultant to overseas hospitals, including Al-Watany Eye Hospital. He specializes in tube surgery for complex adult and pediatric glaucoma, as well as minimally invasive glaucoma surgery like the one we're going to see this evening. The case he is managing the 35-year-old male patient diagnosed with pre-perimetric glaucoma in the right eye and advanced glaucoma in the left eye, for which he had underwent trap surgery some years ago. He's currently on beta blockers and carbonic anhydrase inhibitors for the right eye and no drops for the left eye. This corrected visual acuity is 6.6. Intraocular pressure is 23 millimeters of mercury under medications, and his CD ratio is 0.7. Plan of Dr. Armouti is right Zen implant, and he's going to show us a new technique of implanting this device. We are happy to receive questions at any moment of time, Dr. Saleh.
But can you hear us, Dr. Fawzi?
انتوا سامعين الراجل؟
ما شافوش يعني حاجه؟ يشغل، عايز يشغله.
عايزين اكس واي شويه سنتر الصوره.
To try to make the eye as quiet as possible. Period. The Mito, 0.4 milligram per ml, and the volume is 0.1 ml. And then I inject the Lucentis or anti-VEGF, whatever you have in your hospital, and the subconj steroids and antibiotic to make sure that there is no much healing in the post-operative period. Again, here is the Zen. You don't need to inject any fluid inside the AC to prime the Zen. The Zen is there, and it's very nice bleb, and it's working definitely. Thank you very much.
Unfortunately,
Thank you, Dr. Ahmed. Now we move with our 1 second moderator, Dr. Amr Al-Aouni.
Thank you, Dr. Fatih and Dr. Ahmed. We are still going on with the blepharoplasty. We have finished the markings in the upper eyelid, and now we're going to proceed with the incision.
Wait forward.
Dr. Muhammad, please.
Before I shift to the incision, I want to show you something. The pinching, we stopped at the pinching. Before I start, usually I want to make sure that the amount of skin I'm going to excise is okay. You can do it with any forceps or with this blepharoplasty forceps. Just put the two edges at the two incision sides, and you pinch the skin. You see that the eye is not open. This means that the amount of skin is going to be excised is okay. Is not going to harm the closure of the lids.
Okay, is there a minimum amount of skin that must be left?
Yeah, I just said about when we started, the idea is not the minimum amount. Some people, they say 10 from here, from the lash to the incision, to the crease, and 10 from the brow to the upper incision. Actually, the amount from the hair, from the lashes, from the lid lash to the crease should be the same like this, the upper incision to the brow, which is around 20, more or less. Okay. This depends on the lower part of the crease. If the lower part of the crease is 9, the amount here is 9 or more. 10, 10 or more.
Okay. Now we're proceeding with the incision.
Dry. We excise only the skin scratch incision. We don't go deep because we don't want to injure the muscle. So we will have bleeding. Sometimes the injuring the muscle is inevitable. You will do it well, even if you are very cautious.
What about the role of cutting cautery, Dr. Abdul Hafiz? Do you use it?
I never use it. It causes very high amount of heat into the lids, and you have to put a shell to protect the eye, and this is not convenient to the patients while you operate for 1 hour under local anesthesia. We have it here in the hospital, but I have never used it.
Okay.
Actually, I was very afraid from using it because during my training at Bascom Palmer a long time ago, I saw one of the cases was referred to my mentor, Dr. David C., with the total injury of the eye, of the lid, because of the use of the radiofrequency cutting tip of the skin. So I have this nightmare, and I don't want to see it in my patients.
Okay. What about extending the incision at the medial and the lateral angles? Is there like a certain distance that you have to respect?
I will tell you. I will show you in a minute.
Okay. While we are going on with the blepharoplasty, please, if there are any questions from the audience. Any questions from the audience, please?
Can you hear us?
The lateral extent of the incision.
Egypt, can you hear us?
Yes.
Yes. Yes.
Oh, beautiful.
You can hear
so
you
for
very
Dr.
well.
Abdul Hafiz, I have here Dr. Khalid Abu Halika, oculoplastic surgeon. Possibly he can share some questions with you at the moment.
Yeah.
Dr. Mohammed, can you hear me?
Yes, I hear you. How are you, Dr. Khalid?
Dr. Mohammed, I'm just curious. You're using a 15-degree blade? 15 blade, right?
No, it's 15C. It is micro 15, not 15.
You prefer that?
It is, I will show it to you again under the camera. You see, it is the 15, but it is smaller than the 15. It's called micro 15, not 15. This is my preferred blade in blepharoplasty.
Very good. And you're using the local anesthesia mixture
I'm going
of...
to remove that with the skin.
Yeah.
Xylocaine adrenaline, 1 to 200.
Yes.
200,000. Dry here. And as you see, Khalid, now I'm separating only the skin. I don't remove the orbicularis now. Generally, I don't remove orbicularis muscle, or minimum removal of orbic if I need. But usually I avoid excising the orbicularis in this blepharoplasty.
Yes. So just the skin.
Okay, so Mohammed, we can move now to our healthy, and let's see how it goes. Our keratoplasty.
Thank you, Rimon. And we're back to Dr. Nader with now he has both the donor and the host, and he's carrying on with the surgery. Nader.
Loosely, and it's very easily detached, really. It's not a problem at all. And I'm going to leave it lying loosely on top of the cornea. And I'm going to go now to the patient. Adjust the picture. Okay, and as you see, we have the stromal opacity in the middle of what we you can call laser trephinated. And I'm now going to try to detach this graft as you would do with a regular refractive surgery, as you do with a regular LASIK. And it's usually very, very similar to the same technique you have. It's a thick flap, and you know when the thicker the flap, the easier it is to dissect and the easier it is to manipulate. So we have this now. Colibri. Going to remove this sticky part like a rhexis, and it's very easily removed. Now we're left with the interface. We're going to transfer this cornea, loosely appositioning it. And just like a LASIK procedure, we're going to use fluid to align and to make the good apposition for this flap. Okay, and what I usually like to use to make sure that the interface is clear, I use an applanating lens coming from the top to squeeze any residual fluid outside. Okay.
Dr. Nader, is the superior-inferior orientation matters in such cases?
Yes, in this particular cornea, actually, I looked very thoroughly before we started. I found that the cornea is actually very supreme, because our cornea persons delivering the corneas, they know we have live surgery, so they're very keen to give us very nice corneas. I could only know the horizontal and the vertical plane depending on the corneal diameter, but I really couldn't find any pannus. If I do, and I have a cornea with this clear pannus, then I am very keen to have this pannus at the superior part when I implant the graft. Okay, so now while it's dry, we're going to, can you switch the screen to my side a little bit, please? Yes, please. Okay. Isbat, isn't it one line?
Can we ask a question to Dr. Nader?
Yes, please. Please do go ahead.
Beautiful. So, Dr. Nader, in terms of size, since you are cutting from the epithelium, is it matching same size or do you aim something bigger?
So, while I'm showing you this OCT live image, I'm hoping the camera you can see this live image. I do have 200 microns of the donor and the graft cornea the same. The donor and the host cornea, sorry, the same. And when I'm doing that, the epithelium is still on. When I remove the epithelium afterwards, of course it gets thinner. It may be 150 microns or so. But I am relying on the fact that the epithelium from the host will cover this graft and hold it in place and contribute to the missing 50 microns of epithelium we can see. So now when we look with the OCT image, can you see the OCT image, Dr. Salah?
Yeah, it's very clear.
Yeah, it's very clear. You can see how nicely adapted this cornea is to the underlying interface. There's nothing lying in between. And this very nice coaptation is a very encouraging sign before we leave the patient. So what I'm going to do now is contact lens. I'm going to put a contact lens. Lumera 700. I remove the epithelium because I'm not going to put any sutures. Before I talk about that, a very important tip when I put the contact lenses, I am using this contact lens upside down, and I put it on the cornea upside down, and then I flip it to be stuck on the cornea like this, trying to avoid air bubbles like these really. And the idea is that when I do that, I don't have to manipulate the cornea much after I put the contact lens.
How long exactly do you leave the contact lens?
I leave it at least for a week, until I am very sure that this cornea is stable and the epithelium has grown on. What you regularly see is 2 or 3 days after the surgery, you see that the patient has these epithelium lines closing in, like you see them in PRK surgeries. After 1 week, when the epithelium has been completely exchanged, that's when I'm more confident that the cornea is stable. So this concludes the surgery, actually.
Thank you, Nader, very much. Beautiful surgery. And now we need to go back to Dr. Asef and see what the end result looks like.
Yes.
Explain to us, what did you do?
Yes, it was a huge dialysis here. We closed first of all, we closed the defect of the coloboma by 2 single pass 4th row stitches here. And now we have a dialysis. Now we prepare the dialysis by double arm 10 proline sutures. Now I'm going to titrate the tension, and just before closure of the wound and closure of the conjunctiva.
Dr. Sabi, any questions from the panel to Dr. Asef?
You can see that we have already a fairly rounded pupil, almost central, so I think this will satisfy the patient in the post-op. I will trim now the stitches, okay, and then we'll close the conjunctiva, and now we have concluded the surgery. You can see here, and now here. And I will just bury a knot here inside the scleral tract, and we have done now with the surgery.
Your case is now looking really very
now
good.
Going to close the conjunctiva incision here.
This was beautiful, Dr. Asef, but we have to shift to another surgeon. Thank you very much for your beautiful surgery.
Thank you.
Thank you. And please go ahead with your comment, Dr. Asef.
I wanted to know whether he did just a single suture for the repair of the urododialysis, like a hangback suture, or did he do the sewing needle technique?
Our quadrant, we have a pretty hard cataract and old age IFIS patient. He was in alpha blocker, and we expected the pupil getting down while doing the surgery. And thanks God, the pupil didn't go down. And as you can see, we did pupilloplasty for the coloboma, but of course you have to expect the unexpected. It was a dialysis while doing the first stitch to close the coloboma, and we could successfully manage those dialysis with the double arm stitches here, one from here and one from here. Now there is a track here in the partial thickness track in the sclera, and the knot now has been buried in this track. You can see here now the knot has been already buried, and now we're going to close the conjunctiva and just conclude the surgery.
And for
Good,
the
thank you,
pupilloplasty,
Asef, and we'll continue questioning.
Yeah, for the pupilloplasty, what kind of suture did you use? What was the technique of the knotting? Was it for the closing of the coloboma?
And the single pass. Yes, single pass 4th row knot.
Okay.
Single pass. Yes, it's FT, yes.
Yeah, I find that technique really
And I did the partial sphincterotomy here. Yes, and thanks to Amara Grawal and Priya Narang, who has published this technique last year, and we did partial sphincterotomies here because, as you know, with the coloboma, the already McPherson, because the sphincter papillae continue to the base of the defect.
Thank you, Asef, and we want to go ahead, and there will be more chance to interview Dr. Asef when he comes to the interview room. And now we have Dr. Ahmed Yusri El-Armouti, who just quickly finished a case of mix.
Mix, yes.
I hope you could manage to see something out of this quick surgery.
Very fast, super fast.
So please go ahead and receive questions from the panel. Dr. Saleh, please.
Doctor, first of all, congratulations. It was a beautiful surgery, faster than my capsulorhexis. So it was really a quick one. Now, Zen is kind of a new product for some of us here, and I think you did it very elegantly. Can you give us your feedback on, since you've been using it for a good time, outcome of Zen, your experience with it as well?
Okay, the Zen
one of the few MIGs that can have a bleb, like the InFocus. And I personally like the MIGs that have the bleb because I can do something about it if it starts to scar down, rather than those who are only inserted in the angle when your arms are tied behind your back and you cannot do anything if the pressure starts to creep up. First of all, the Zen has come as very easy and simple procedure, but the problem is the aftercare or the homework for a bleb surgery, like the trap or the InFocus. You have to know when to intervene at the proper time, not to delay it, manage the problem or the complications of the bleb, and try to be as interventional as possible, not to wait and wait until it fails down. Probably it will need considerable or significant percentage of needling, and you probably will need as well to use high dose of anti-scarring medicine like mitomycin C, 0.4 milligram per ml. I don't do 0.2 milligram per ml, and I think using as well anti-VEGF subconj helps a lot in making the bleb looks much more nicer.
Any other questions?
Well, actually, we have a comment, if you don't mind, since we have we could not do the proper introduction at the beginning.
Please.
And this is actually for the room, which is full here, and for those people watching us online, since the live surgery is streamed. The cases all booked today are challenging cases. These are cases you don't see in a live surgery. These are cases only certain skilled surgeons will accept to do within a context of a live. Seeing it and watching it through hundreds and hundreds now. And I have to acknowledge that Dr. Fathi, Dr. Abdullah, and the team of Al-Watany Hospital possibly were the only and the one that I trust to ask them to do this kind of surgeries. The plan is, even if challenges happen or complications happen, we have to stay tuned for that. That's part of the package. And if you've seen, they were trying to show even the small screen what's happening with Dr. Ahmed. So that's the whole idea, how to manage complications in a real life scenario. So I have to acknowledge that, and I have to thank you all for the outstanding job that you are doing.
Thank you, Salah, and we really treasure this comment and we're happy about it. And please allow us to carry on and see what's going on the blepharoplasty case. Dr. Amr?
Thank you, Dr. Fathi. We are now returned to the blepharoplasty by Dr. Abdul Hafiz. We have removed the skin and we're going on with the section. Dr. Abdul Hafiz, please.
Now, as I said before, I don't excise orbicularis as much as possible. Only it's in this case, I haven't excised any orbicularis muscle. And regarding the fat, I always preserve the middle compartment of the fat because this gives the contour of the upper lid, the sulcus, the depth. If you are going to remove the fat from this central part, the patient will have deep sulcus. She will look ill after the surgery. I only excise the nasal compartment if it is herniated, if the patient has excess, and it is very simple to identify the nasal compartment from the other fat because as you see in the camera, the nasal compartment is whitish yellow. It is not yellow as the other fat. All the nasal fat in the upper lid and the lower lid is like this. The other fat, if you are coming to visit this room later on, when we excise the lateral compartment, you'll see that the lateral compartment is dark yellow. And I always excise the amount which is anterior to the bone, to the rim. I don't fish to excise fat. The amount which is herniated anterior to the orbital rim. My preferred way of excising the fat, I don't use radio frequency. I usually prefer to cauterize, excise, so I don't like to put clamping. I don't want to pull because pulling will cause pain to the patient, and if the patient moves, this might evulse the fat from the posterior attachment with the ciliary vessels, causing severe hemorrhage. So I prefer to do monitor or controlled excision, cautery excision.
So Dr. Mohammed,
any questions from the audience or from the panel, please?
Yes, Khalid.
Dr. Mohammed, do you?
Yes, we can hear you.
Compress the fat with the
Yes, mosquito? I hear you well. Yes, go ahead.
Can you hear me now?
Sorry, can you repeat the question?
I heard him. Dr. Khalid is asking if I use mosquito in the fat. No, I don't use mosquito because I said the pulling, using the mosquito or the clamp is a little bit painful in the local anesthesia, and it carries the risk if the patient moves while holding the fat, it will evulse the fat from the posterior attachments, causing severe hemorrhage. I like to do this way, controlled cautery and excision, and at the same time I control the fat which is herniated, I don't pull on it.
Okay, now we are moving to another challenging cataract case. I'm proud to introduce my ex-fellow and now my colleague, Dr. Bassem Faiz, MD, PhD, lecturer of ophthalmology at Shams University, consultant of cataract and refractive surgery at Al-Watany Eye Hospital. His case is a case of brown cataract. On examination, the best corrected visual acuity is 0.05. Anterior segment show poor dilatation. Shallow anterior chamber, brown nuclear cataract grade 4. Investigation was done, speculum microscopy and B-scan ultrasonography. As you can see, the picture of the B-scan showing a normal retina. The anterior chamber depth is 2.5 only, so it is a shallow anterior chamber. The axial length is of 21 millimeter. Here is the speculum microscopy showing some lost cells with a CCT of 540. Now, Professor Bassem Faiz, please, can you explain to us your case?
Good evening, everybody. Now I'm start this case. It's quite tough case. I'll start with the paracentesis to do staining of the anterior capsule. As you can see, the red reflex is very dim. Now I'll inject air in the anterior chamber. Air, please. While injecting air, I remove some aqueous from the anterior chamber to get well uniform air bubble in the anterior chamber. Now, I stain under the air. As you can see, the pupil is not well dilated. I'll do the surgery through 2.2 millimeter wound using the signature Pro machine. Okay, let's go, please.
How do you overcome this shallow anterior chamber? Do you give mannitol preoperative or just you put some dispersive viscoelastic?
Yeah, some dispersive viscoelastic. I'm now, as you can see now, I'm using the viscoat. Now I got a very, I think it's quite deep anterior chamber now. Now I will start with the capsulorhexis. The cornea is a little bit hazy. I'll try to do a 5 or millimeter capsulorhexis and central and well rounded. In case that if I need to implant a sulcus IOL or something like this. Now this is the capsulorhexis. Now it's finished, well-rounded and central. It's about 5 millimeter. I remove some viscoelastic from the anterior chamber and go for high dissection. In these hard cases, I prefer to do multiple quadrant high dissection because the nucleus is quite big. So in order not to increase the interlenticular pressure, I prefer to do multi-quadrant hydrodissection. But because the case is tough, the red reflex is very dim and the wave is not well seen.
Now, as we can see that Dr. Bassem is using another platform. He's using the Signature Pro, while Dr. Asaf was using the Centurion of Alpha.
Now, I succeed to rotate the nucleus. More dispersive now to start the case. Okay. ease aspiration, please. The case is quite tough, as you can see. I'll try to remove the shutters. I'm not doing here I'm using the stop and chop technique. I'm trying to get a very deep groove just to facilitate the division of the nucleus. I prefer to use this type of chopper.
So why not a quick chop like Dr. Assaf?
Actually, the lens fibers are very hard and tight together, so I'm afraid not to make a complete division of the nucleus. And there is a strong isthmus usually in these cases.
Dr. Masab, you are waiting for your question and the panel question.
Now, I think it will be divided now.
Dr. Fayez, Dr. Yeo from Singapore here. You've got a very difficult case ahead of you. Brown nucleus and shallow chamber, but you're doing it beautifully. I just wondered, you know, when you started the phaco, you had a plume of milk coming out. Why was there such little flow that you had that milk coming out?
So the question is why the milk came out during at the start of the operation?
I think this is from the hardness of the nucleus, and the aspiration was not set to high level. So it retained in the anterior chamber until I removed it.
And that's very
now
important.
I'm using the chopping technique in a piece of pie. This is the first half. It's quite tough to be divided. I'm trying always to be at the level of the iris plane, or to do phaco inside the bag to be away from the endothelium, because the anterior chamber is quite shallow.
Are you still in peristaltic mode here? Because one of the advantages of the Signature Pro is you can switch between peristaltic and the more efficient Venturi system. And I quite often like to do this when I've chopped it into small bits. Then I go to Venturi to take away the pieces. So because we can't see from here whether you're in peristaltic or Venturi mode here.
I think it's written peristaltic.
Yeah, no, I'm using this is the first half. I'm using the vacuum set to 400 or more. It's using the linear vacuum. I need the parts to come at once, and I'm not afraid about the posterior capsule because the other half of the nucleus is making a support to the posterior capsule. Now we'll move to the second half of the nucleus. Now I will change the mode of the vacuum to linear one, because I will use the case mode, which gives me protection to the posterior capsule. And this is a unique feature in the Signature Pro machine and all Signatures platform.
So you start with the panel vacuum, then at the last part of the cataract, you shift to the linear type. Okay.
Yeah, because in the linear mode, I can use the case mode to protect the posterior capsule, because it gives me the maximum vacuum at maximum to maximum holdability of the nucleus, and then it will decrease for a while to prevent surge and collapse of the anterior chamber.
What type of power modulation are you using for this dense cataract?
Can you repeat the question, please?
What type of power modulation are you using for this dense cataract?
So the question is, what type of power modulation are you using in this dense cataract?
Phacopulses, long phacopulses. The anterior chamber is shallow and
sometimes it's useful to top up the OVD during these very dense nuclei that you're in the eye for quite a long time, and just for corneal protection, that's something that's useful. You weren't kidding when you said
I'm using the dispersive to protect the endothelium. Yeah.
It's not only a hard cataract, but it is to a small anterior chamber or shallow anterior chamber of 2.5. So things are a little bit tight. But I think that Dr. Bassem is doing pretty well, and he's about to adjourn or finish the case.
Now, this is the most dangerous part, as you can see, because we don't have here an epinucleus.
Maybe you need to see the capsular rhexis edge in front of the phaco before you come out.
Viscoelastic, please.
Yes.
Now, I don't want the anterior chamber to be collapsed. So before removing the phaco tip, I'll inject viscoelastic inside the anterior chamber.
So the whole cataract was a nucleus. We don't have any cortical material.
Yeah, just a very small part here in the upper part. Very small pieces of the nucleus here. I can make it I think the aspiration port is now locked. Okay. Now I'll implant the posterior chamber IOL. It's a single piece IOL, thickness 1. Its power is 28.5.
Can you show us this slip in the anterior capsule?
Yeah.
Okay. Can you check 6 o'clock before you implant the lens, please? 6 o'clock at the capsular rhexis.
Yeah, it's 6 o'clock. I want to check it before the implantation. No, it's a very small part. You can see here it's a small,
continuous capsule.
Yeah, it's still continuous. I think it's from the sharp chopper I used, but fortunately it's good, and we can implant in the back safely.
If it was a larger cut in the anterior capsule, where will you put your intraocular lens?
I think I will implant a 3-piece IOL. It's safer. And I will implant it in the sulcus to be safe, not to make an extension from the anterior capsule to the posterior one.
Okay, we will stop at here. And Dr. Amr, please.
First, I would like to congratulate Dr. Nader for this very neat operation. Actually, it gave us a magic solution for those patients coming with opacities in the cornea that are too deep for PTK and not deep enough to do penetrating keratoplasty. How did the idea start, Dr. Nader?
Well, we are shifting completely from penetrating keratoplasty in those cases, especially this is a young man, 23 years old, and he has an excellent endothelium. There is no reason for us at all to be removing this young man's endothelium. Again, a deep anterior lamellar procedure, which has been our gold standard now, is removing a lot of still healthy tissue. And since the opacity is still very superficial, we derive the idea from a refractive surgery knowledge. We know that patients in earlier days of the microkeratome surgery who had free caps just had these free caps positioned on the cornea, left with a contact lens, and they adhered quite nicely. So we got the idea, why not respect the rules of refractive surgery in terms of residual stroma and what biomechanics of the corneas is regarded, and try to remove, as if we are removing a flap, intentionally creating a so-called free cap, and then using clear graft tissue to replace the diseased, scarred tissue that is causing the distortion of vision in such a patient. And we tried the idea. Your worst case scenario really is that the patient might lose this graft. So there are two solutions if this happens. The first thing is they still can see, and you can leave it as is. The epithelium would fill the defect. That's not very ideal, but you can also regraft the patient over and over again. Just be very careful to remove all the epithelium nicely and then regraft it. Luckily, I have not needed to do this since I started practicing this technique. But even if I'm imagining this as a worst case scenario, still, it can give a very good outcome.
So, any question from the panel to Dr. Assaf?
Well, actually, I have questions for both of them. It depends on how you decide from your side. Maybe, Ahmed, congratulations. It was a heavy and very happy Valentine for you. What a tough case, but I think you did an outstanding job. I have here the panelists with me. They were really impressed how much you were able really to control the scenario in a very calm way. And I'm sure here as well the audience enjoyed it. We were also happy that you showed part of it at least during the suturing, and eventually the case will really ended up very well. I think there are some points that we can raise from Professor G and Dr. Ronald.
Dr. Assaf, congratulations. Wonderful surgery on a difficult case. I just wonder that having done it so well when you got the nucleus out, and you put in a 3-piece lens just now, didn't you?
Yeah, he did 3-piece
because of the zoning. So I was wondering why you didn't put a CTR in and just put a single-piece lens in, which seemed it would have received that quite well.
Well, very nice question. This is a good alternative. We can put CTR and then single-piece lens inside the capsular bag, but I didn't want to complicate the surgery much more. So according to my experience, in such cases when there is some localized zonular dialysis, only a few clock hours, we can manage those cases quite well by implanting the 3-piece lens inside the sulcus and just capture the optic within the rhexis. And there is no tilt, there is no centration, as long as my rhexis was in the middle in the very beginning. So this is according to my experience. I didn't to complicate and use a CTR, and probably this is already a complicated case, but of course this is a very reasonable to put a CTR inside the capsular bag and single piece lens, but I prefer this way.
Thank you.
If you are obliged to put a CTR, at which part of stage of the surgery you will put it?
If I would put a CTR, definitely I will put it after cortical cleanup. CTR might make the stage of the cortical cleanup a little bit tedious because sometimes the cortex is caught within the fornix. But if I had to put a CTR, whether the normal one or the Sioni type or whatever, I'll just put it right away after cortical cleanup, because I've already suspended the capsular bag with the capsular system of MST. I don't have any financial interest, by the way.
Congratulations on an excellent job.
Any questions for Dr. Nader, please?
Can I ask, can I bring up another point? I'm just wondering whether in this case of a coloboma that involves the iris, was the coloboma also extending towards the choroid and the retina? And if it was so, do you think that reconstructing the pupil would make a significant difference to this patient's vision?
Well, we couldn't examine the fundus in pre-op because of the dense cataract. The UBM and the B-scan didn't show coloboma of the iris, of course, so we couldn't see any coloboma of the iris, of the choroid and the retina, but it's very expected to have coloboma of the retina and choroid, And definitely, we have a guarded prognosis for this patient that the potential vision won't be very well. But at least this patient might be bothered by the dysphotopsis that comes from the edge of the lens and the capsule. So probably closure of the coloboma and trying to centralize the pupil, at least in the early post-operative period, will benefit the patient. Definitely, this issue will be solved out by the capsular fibrosis later on, but it might take about 2 or 3 months until the patient is completely free from the dysphotopsias. So I would prefer in such case try to reduce the dysphotopsias by trying to bring the pupil around it and central as much as possible to be away from the edge of the lens.
And it's always elegant in a live surgery to show how can we close the iris, the defects and dialysis and things like this with a magnificent surgeon as Dr. Assaf.
This is another indication, yes.
Dr. Nader, can we ask a question still? Do you have time for that? Okay, I can't hear you, but I hope we still can hear the answer. Very brilliant technique and concept. Obviously, the option here to do this kind of keratoplasty is to have the visual rehabilitation faster and the visual outcome. Can you share with us if you have any numbers, how many cases you've done with this technique, and what was the visual outcome, and how fast?
It really depends on what the patient is complaining of. One of the cases had more than 8 diopters of cylinder just in the central cornea. And you know, when you put sutures into the cornea, they don't have an immediate, wonderful wow effect after the surgery because of the astigmatism caused by the sutures themselves. In this surgery, actually the patient's 1 or 2 weeks on, after the cornea has cleared, it looks just like a post-LASIK procedure. That one particular patient went down from 8 diopters of cylinder down to 1.25 diopters. Of course, that was a magnificent result. In this case, this patient does not have that much cylinder, but he has a lot of higher order aberrations because of the scarring happening paracentrally, just next to the pupil or barely bisecting the pupil. He has in his central area of vision, in the visual axis, a part which is very flat and a part which is very steep. And this is causing him to have a lot of distortion of vision. And these symptoms are practically completely relieved within days, maybe 1 or 2 weeks after the surgery, which is a huge advantage.
I'm going to book my ticket to come to learn it from you, my friend. I hope you have an extra room spared in your apartment.
My friend, I am sure you will, with your expertise, it should not be a problem.
Very kind of you.
So we can shift now to another surgeon. Dr. Masabi?
Yes, please.
We will shift to another surgeon now.
Please. And we also will shift the moderators and the panelists here. So by the time you carry on, Dr. Muhammad Husni and Dr. Murtada and the rest of the panelists will be changed while Dr. Ashraf starts his case. Thanks a lot.
Thank you, Dr. Musabi. Thank you, Abdullah. Now, the next surgeon, one of our brilliant staff, used to be my fellow and now is a colleague consultant of cornea, cataract, and refractive anterior segment reconstructive surgery at Al-Watany Eye Hospital. He's a member of AAO, ESCRS, ASCRS, and ACOS Europe. Dr. Armey actually is a very known face in most of the international meetings. And again, there's another color of cataract. One of the other challenging situations is dealing with a white cataract in shallow anterior chamber in a 53-year-old male. He has poor vision in the right eye, only hand movement with good projection. Ultrasound is fine, apart from few floaters in the vitreous cavity. And he is planning to implant a thickness lens and a 19 diopter. Please go ahead, Ashraf.
Thank you, Dr. Fathi. It's my pleasure to share in this live surgery. Thanks to Dr. Musaibi. This white cataract, my aim is to do staining, first staining of the capsule. Take care that the fluid in this white cataract does not lead to traction on the anterior capsule during a rhexis to make it happen extension like an Argentina flag. So 1.2 paracentesis in both sides. Okay. And the most important now is to evacuate the fluid in the anterior chamber as you can, so the air bubble will be complete. To make a good air bubble, and we put some viscose to trap this air in both paracenteses so make the air not escape during staining of the anterior capsule. With the trypan blue, just 3 or 4 drops. And then I like to leave it for 5 seconds. Then to wash this trypan, not to be toxic to the endothelium. Then, in this hard cataract, I usually do
Dr. Abdullah,
double shell
can I ask
technique
Ashraf
using
Armia
the
a question
viscoadhesive.
during his steps of the surgery? I'm Khalid Abdurrahman, ya Dr. Abdullah.
Yes. Hi Khalid, how are you?
Dr. Ashraf, God with you in such difficult case.
Yes.
But my question...
I'm using the double shell technique, Khalid.
Okay, great. But do you believe that air inside the anterior chamber will differ in staining, proper staining of the anterior capsule?
Yes, air make the trypan make the staining of the anterior capsule well formed. Then you do it under viscoelastic.
I think with air staining is more fast than with viscoelastic.
Yes, this is true. Because if there is viscoelastic, usually become stained with the trypan.
Okay. Thank you.
So the most important in these cases that you evacuate with insulin needle in the center directly, and you aspirate as much as you can, and you push the nucleus down to make it evacuated. And I will do spiral rhexis
Dr. Ashraf, this is Mohammed Hosni.
Because spiral rhexis...
Well done so far. Very nice staining.
Yes, Mohammed.
Very nice staining.
Thank you so much, Mohammed. Always in spiral rhexis, you make it small, then you enlarge it slowly, and you always make your rhexis to the left side. Slowly, you make it enlarge to the size that you wanted. Always in spiral rhexis, the traction will be always to the center. Always make your rhexis inside your rhexis. To the size you wanted, which is nearly 5 millimeters. So the most important in these cases that you obtain a good size rhexis. In these white cataracts, hydrodissection is not recommended, but you can pass some fluid slowly without too much pushing, just to make the nucleus move inside the bag, that you make a rotation. It seems now
Dr.
just the
Ashraf,
center is a little bit hard. Yes.
Very nice capsulorhexis and very well
Yes,
demonstrated orange peeling technique. But can I ask you, in such cases, you don't afraid that you have such capsular plaque or posterior plaque attached to the cataract, like posterior polar cataract or something like this, if the posterior capsule is fibrosed because you cannot see the posterior aspect of the nucleus? With dialing,
Yes,
you may
totally
open the
agree.
posterior
This is
capsule.
why I didn't do a. Yes, totally agree. This is why I didn't do a gush of fluid during the hydrodissection, just in the cortical layer. So it's make me away from this complication.
Okay.
So I am going to start with just sculpting of the nucleus, removing the first part, the top, some cortex. No. So I use technique, my technique is stop and shop, make a small groove. As much as deep you get it safely. Then I'll try to crack it in two halves. And the most important in cracking, that you see the red reflex. If you didn't see the red reflex, if you didn't see the red reflex, you didn't crack it. Then I'm going to do shopping, vertical shopping. Impel the nucleus good. Then you crack. The same. Impel the nucleus and crack. As you see, there is some layer deep in the nucleus.
Dr. Ashraf, do you see any difference or you feel any difference in occlusion between the Centurion, what we are using, and the Infinity machine?
Yes.
Yes.
In the Centurion, I feel more good in occlusion in these hard cases, better than the Infinity. The fluidity is better here in this Centurion. So as much as you crack your nucleus in these hard cataracts, as much as you make less, because all the CDE now, I will put some visco adhesive because it's hard cataract, and you don't remove your phaco during this to protect the endothelium as you can. And then start my quadrant removal. With a pulse.
Dr. Ashraf, how much ozil are you using right now?
How much?
Torsion.
Usually, whatever the hardness of the nucleus, I depend on the vacuum mainly.
Dr. Ashraf, do you believe that the machine is working very efficiently with such hard cataract, especially with different parameters? You are moving here and there, you are changing the levels of the vacuum, flow rate,
Yes.
and intraocular pressure. The anterior chamber is rock hard stable, so that there is the machine is. Do you think that the machine adds more to the stability of the anterior chamber, whatever the parameters you are using?
Yes, totally agree. The stability of the anterior chamber without any surge make it more safe for removing even the last parts. See how it is nice when you have occlusion.
Yes, I like
I
from
can
the floor
even
to
take
have
the,
a look to
the
the
pieces.
iris during the emulsification, and at the time of the occlusion break, the iris does not move at all. Although the intraocular pressure is only 44 and the vacuum is
Yes.
reaching 600 millimeter mercury. And this is the beauty of this machine regarding the stability of the anterior chamber and the efficiency of the power. The CDE now is
This is
almost
true.
18.
Do you think
And
Khalid,
most of the power.
Do you think Khalid that's Fathi معاك? Do you think it's because the machine is good or Ashraf is good?
Both are good, yeah, Dr. Fathi.
Both are good. Okay.
So I finish
Ashraf, well done.
the nucleus. Thank you so much. And there is some nucleus trapped in the paracentesis, the left paracentesis, which is very common to happen in these hard nucleus when you do a lot of shopping nucleus. So always search for these pieces because you can find them second day in the anterior chamber. So usually it always trapped, there is no fluid. Always there is, these pieces are amalgamated with the visco-adhesive parts. So if you didn't remove the viscous in a good way, you can make it them trapped in the angle or in the sulcus, and you find them next day in the anterior chamber down. So the most important, you don't lose these pieces. You start by them, try to remove it because you are seeing them now. If you didn't see them before, you don't see it again. So start to remove it first before you do anything, not to lose these pieces.
Do you think, Ashraf, that the new technology has aided more in actually seeing this problem of losing fragments because you have such efficient power and shattering of fragments?
This is true, Dr. Fathi. The high technology from Centurium make it is more easy not to have the shatters of the pieces. And you see some cortex. I'm trying to peel them from the recess of the back and remove it from the, see, they are adherent to the posterior capsule. So I want to remove them as much as I can. Slowly, just as I am peeling the posterior capsule. I'm trying to do some polish.
ماشي.
As I can to remove these cells.
Dr. Ashraf, just I want to highlight the incision and how beauty the incision at the end of the surgery. There is no too much corneal edema around the incision. No, I mean the main incision. There is no opacification around the wound as we are encountering with most of the other machines. With the Centurion here, I think the incision is pretty and it seems still sealed to the end of the surgery. Nothing leaking from the main incision during the IA while the intraocular pressure is around 50. What do you think, Dr. Ashraf?
This is true. The energy does not go in during the lumen, during the phaco. The energy is away from just in the tip, not in the shaft. So it make little bit the incidence of corneal burn that can happen. But it can happen if you trap inside this wound with some visco adhesive. It can make the wound burn. So take care of this. So I'm trying to polish as much as I can these cells from the posterior capsule. I hope I can succeed. رجعي الاي تاني.
Perfectly managed as usual, Dr. Ashraf Al-Mayya. While you are doing more polishing, we would like to check how the progress is with our oculoplasty case. Dr. Muhammad Abdel Hafiz, let's see what's going on.
We are now returned with Dr. Abdel Hafiz, going with the blepharoplasty.
I was just waiting for you to show you the difference I told you a while ago. This is, I'm holding in my right hand the nasal compartment of fat, and I'm holding in my left hand the temporal compartment of fat. You see the difference? Can you notice the difference? This is very pale or whitish yellow, and this is yellow. The point I'd like to stress here while excising this temporal part, you have to be cautious from the presence of herniated lacrimal gland of many patients. It has a characteristic mulberry appearance of the surface of the white surface of the lacrimal gland, and it will be, would you dry this please? It will be herniated in this area, just temporal below the superior orbital rim. So sometimes when you excise this temporal part of fat, the lacrimal gland will be herniated and you will excise it wrongly, and this is very wrong to happen. It shouldn't happen with oculoplastic surgeons. So you have to, before excision, check that the lacrimal gland is not herniated. If it is herniated, you just pull it back like this. If you see, hold this, and you take a suture, non-absorbable suture like Ethibond Merceline to the superior orbital rim behind this rim, so it keep it in position, so it will not be herniated, not producing any bumpy appearance of the temporal part of the upper lid. And I'm going to excise the fat, the same way I usually do.
Any question from the audience to Dr. Abdel Hafiz?
Okay.
Do you hear us?
Yeah, okay. We're now going to shift to the interview with Dr. Bassem Faiz to tell us the story of the very difficult case that he was facing a few minutes before. I'm handing over to Professor Dr. Abdullah Hassouna.
So Bassem, I congratulate you again for this wonderful surgery. Thank you. And I want to ask you, in your machine, there is a peristaltic and a Venturi mode. And you are always using the peristaltic mode. Why don't you use the Venturi mode?
Yeah, in such hard cases, Venturi may be better for the case, but here the case, the anterior chamber was shallow, and the iris was, the pupil was not dilatable well, so if I use the Venturi, the iris may be entangled inside the phaco tip while I'm using the Venturi mode of the vacuum. So I prefer the peristaltic mode and change between the linear and panel vacuum.
Any question from the panel?
No, just a quick comment. It was a very, very well managed case, Dr. Best. Very nice. And
thank you. Thank you, Dr. Muhammad.
So again, can you tell us about this panel? You start with the panel mode, then you switch to the linear mode.
Yeah.
Can you explain to the audience why you're using this?
Yeah, because the panel gives me a good holdability for the nucleus at once. The first half I can hold it well by the vacuum while I'm using the panel vacuum, and I'm not afraid about the posterior capsule because the other half of the nucleus is protecting the capsule, so it's away from the phaco tip. And while I'm emulsifying the second half, I shifted to linear mode just to use the case mode, which is a feature of the Signature Pro.
I will ask Khalid a question. You have a rip in the anterior capsule.
Dr. Abdullah, we cannot hear you. You're fading away. You cannot hear you. The voice is not that good.
Can you hear me? Hello? Can you hear me, Dr. Khalid?
Yes, now I can hear you, Dr. Abdullah.
Okay, so the question
but there is some noise.
If you have a rip in the anterior capsule like the one, yeah, now you can hear me?
Yes, can you repeat the question, please, Dr. Abdullah?
Yeah, if you have a rip in the anterior capsule like the one.
No, we can't hear you. We can't hear you.
In the back, because I usually do this.
We can't hear you, Dr. Abdullah. Would you please to make sure the microphone is working, please?
Now you can?
Yes, this is good.
Dr. Khalid?
Yes, now go ahead.
Okay, so my question for another time is, if you have a rip in the anterior capsule like the one that Bassem had, or maybe a bigger one, would you consider implanting a single piece intraocular lens in the bag? Because usually I do this and I find it harmless.
Actually, the bite of the anterior capsule that Bassem had, I think this is because of the phaco tip, not because of the tuber. Because tuber will do a complete rent in the anterior capsule. And fortunately, many times it does not escape into the posterior capsule. But my advice during implantation of the IOL is to implant the single piece IOL into the anterior chamber first, then to make the IOL perpendicular to this rent, and then to start to feed the bag with the haptics one by one to make the haptics perpendicular to the rent of the anterior capsule. And even if the bag is opened, this single piece IOL will be supported by the two leaflets of the posterior capsule. And Dr. Hassan Murtada
Thank you, and we'll shift now
add
to Dr. Ashraf.
Abdullah, this is Hassan Murtada.
So maybe a small question because you have to shift to Ashraf.
Abdullah, this is Hassan Murtada. Can you hear me?
Yes, Dr. Hassan.
I totally agree with you when I have a rent in the anterior capsule and the patient is not highly myopic, I prefer to insert one piece lens because this is impose little traction on the capsule and there is no risk of this rent extending into the posterior capsule. But when the patient has high myopia, I prefer to insert a three-piece intraocular lens because the one piece may be small for this eye. So I usually guide the leading haptic away from the rent, and then I rotate the lens so as to insert the other haptic. So I think this is maybe a good policy for dealing with rent in the anterior capsule.
Yeah, Dr. Hassan, I agree 100%. This is what I'm doing, and we are shifting now to Dr. Ashraf Armia to finish his case.
Yeah.
Thank you.
So what I'm going to say that I put an aspheric IQ lens. The most important now is to decrease the negative dysphotopsia. To decrease it, as in literature now and all papers, you put it in upper temporal. The haptics put it in upper temporal. That this way is going to decrease the negative dysphotopsia as much as it is. I try to polish the posterior capsule. The rest is the fibrous part. So I leave it for 2 months, 2 to 3 months, do egg for this patient. Put it in the bag with a well-formed rhexis and upper temporal position of this aspheric lens. Thank you.
Seems that our oculoplasty case is about to be finished. Let's see what the progress with Dr. Mohammed Abdul Hafiz.
Yes, Dr. Abdul Hafiz, please tell us how are you reforming the crease once more?
Actually, when you reform the crease, you do it only when you change the position of the crease. If you are not going to interfere with the crease, with the existing crease, you don't have to reform it. But if you have to reform the crease, you have 2 ways. Either you take skin orbicularis, levator orbicularis skin, in case if you need a very prominent crease. If you want to make a faint crease, you can take only the suture from the orbicularis, levator, or beak muscle. You don't go through the skin to make a faint crease. I now finished the 3 sutures in the middle, the interrupted I usually do, and then I prefer to always close by doing continuous running sutures. I leave always the temporal part to make it interrupted like this. Yeah. So when I start doing the continuous sutures, I leave the temporal part of the incision to be closed by interrupted sutures. Then I do the whole incision continuous running sutures.
Dr. Mohammed, what suture are you using?
I always prefer to use the 7/0 nylon suture enclosing the skin in the upper lids. Some people, they prefer they use it with silk, but I don't like the silk because it is braided. It has a lot. It can contain discharge with the patients after surgery. The nylon is much better in my hands.
When do you remove it?
Okay, any other questions for Dr. Abdul Hafiz?
You intended to ask a question?
When do you remove the sutures?
I remove the sutures. Usually you can remove them 5 days after the surgery in the upper lid because the lid is vascular, but I prefer always to leave them in 1 week.
Any further questions? Okay, thank you, Dr. Abdul Hafiz. We are now moving to a vitrectomy case.
If you have the camera, this is the appearance of the lid after closure.
Sorry?
If you have the camera,
okay.
I finished closing the upper lid, the right upper one. You can see the right upper lid is closed now, and I'm closing the left. This is the appearance after closure.
It's a very nice operation, Dr. Abdul Hafiz. Thank you very much. Now you are shifting to Professor Dr. Fathi Fawzi with a case of vitrectomy for Dr. Maged Mikhail. Thank you.
To the next surgeon, one of our eminent vitreoretinal surgeons, Dr. Maged Mikhail, who is a vitreoretinal consultant at Al-Watany Eye Hospital, and he is the head of vitreoretinal department at Governmental National Eye Center. And his case is a 60-year-old male patient complaining of left defective central vision. His post-ocular history, actually, he underwent bilateral phaco 9 months ago and is now pseudophakic. His best corrected visual acuity in the left eye is 0.3. And if you look at his OCT, he has a full thickness macular hole in this left eye. And the plan of Dr. Maged, by using the eye OCT assisted 23 gauge parsiplana vitrectomy with an inverted ILM flap technique, Dr. Magid just told me he's happy that Dr. Hassan Murtada is there, witnessed this surgery. Dr. Magid, please go ahead.
Thank you, Dr. Fathi. And
the pleasure is mine, Magid.
All of you. It's a pleasure for me, Dr. Hassan. You are my professor since many years ago. And always I learned from you a lot.
Thank you, Magid.
This is the case, as Dr. Fathi said. This is the case, as Dr. Fathi said, full thickness macular hole due to ventricular traction from anomalous posterior hyaloid detachment. And my plan is a new technology of intraoperative OCT-assisted surgery of macular hole with inverted ILM flap. This technique introduced by Mikuliska since 2010, and I usually prefer this technique. I started my surgery by removal of the anterior hyaloid. As you see, this case is pseudophakic, but the lens is partially in the bag and partially in the sulcus. And I started to remove the anterior hyaloid meticulously just behind the IOL. As you saw in the OCT, there is a vitreomacular traction, which indicates that is a primary macular hole, large macular hole, which previously mentions as the idiopathic macular hole.
Magid, what viewing system you are using? Because the picture is really amazing. Very good picture.
It is a Recite Zeiss, and the microscope is Lumira. I did a considerable amount of vitreous removal, and I will start to induce BVD just temporal to the temporal edge of the optic disc and activate the vacuum. With side-to-side movement to catch fibrils of posterior hyaloid. We can see the wave now. You can see the wave of BVD propagating towards the periphery. And minute vitrectomy and start peeling. We can see the posterior hyaloid peeled. Okay.
Thank you, Magid. Of course, we'll come back to you. And Dr. Abdullah, if you want to present the next case.
Dr. Rami Riyad, MD and FRCS, lecturer of ophthalmology at Cairo University, consultant cataract and refractive surgery at Al-Watany Eye Hospital and board member of the hospital. He will present to us a case of Yamani technique. It's a 35-year-old patient with a blunt trauma to the right eye with traumatic subluxated cataract. He underwent a luxectomy and was left aphakic. His best corrected visual acuity is 0.6. As we can see here from the picture, the anterior segment examination showed an irregular pupil and aphakia. Here is the ultrasound at the time of the trauma and after removal of the cataract and the biometry. Rami, can you explain to us what's the surgery?
Yamani technique is quite an interesting technique, and it's a new technique. There's a lot of ideas how to use this technique, but the most recent thing is you have to try the haptics to put the haptics into the needle first before anything, before attempting a technique, because whatever the manufacturer can say, sometimes inside the eye, it is too difficult to put the haptic. So we have to start by trying to introduce the haptic inside the needle at first, before doing the technique inside the eye. So it's a very difficult, sometimes, technique to insert, but here it is. We make sure it is going through the needle and going through easily. This is the first needle and the first haptic. And then we take the other needle, we turn the lens, and we try to insert it again inside, and it goes in smoothly. So now I think, okay, my lens is fine, and the haptics can go in easily inside the needles. So we can start our surgery. The first thing is, with the eye closed, is to try to introduce the needles in the right place. And the trick here is you need to be perpendicular on the wound that you are creating. So the places where you will put the needles need to be perpendicular on where the wound is going to be. Okay. So we start by marking where we're going to go in. Need to dry well. This is the instrument used for the glued IOL marker that I'm going to use, but I don't put the ink on all the edges, just 2 of the edges that are parallel to each other, like that, so that I know where I am going to be able to enter, like this, and I am sure they're 100 degrees apart. And then, with a caliper that also has some ink, you start to mark where the point of entry is going to be. 1.5 millimeter away from the limbus. Okay. Once we've marked, we do the introduction of the needle. You need to go at least 1 millimeter, you need to create at least 1 millimeter tunnel. So, simple introduction of the needle, bevel up. And then some intrascleral tunnel, and then shift the direction and penetrate inside the eye.
So no chamber maintainer?
We can add a chamber maintainer maybe when I open the eye. If it's too soft, then we can try to have an anterior chamber, to put an anterior chamber maintainer. It's already, I have it ready, and I can use it if I want. The other part, again, the exact place where I need to puncture.
Rami, you regularly, do not use an anterior chamber maintainer?
No. I use an anterior chamber maintainer.
Okay.
But after I open the eye, after I create my wound, so not as early as that. And then, simple. I think it is too anterior, so I go again and then penetrate all the way through the back where the needle can be seen now. Once I have both needles inside, I start to create my wound. We're going to be using a Sensar 3-piece lens. So again, 90 degrees perpendicular, creation of the wound, and a small paracentesis to put the anterior chamber maintainer on the opposite side.
Is it something in the transmission neuromy where you see like a little bit of bleeding in the anterior chamber?
I cannot hear well.
Can you
repeat the question? Some visco inside the anterior chamber before putting the maintainer, just to make sure I have no vitreous into the anterior chamber. Second instrument. A quick swap into the anterior chamber just to make sure I have no vitreous. It's okay.
So actually,
now
you didn't
we start
do any
with the introduction of the lens.
Before starting. The anterior vitrectomy done already before, yeah?
I don't need here. That's why I checked for the vitreous, and there's no vitreous in the anterior chamber. The anterior chamber maintainer, please. Infusion. Okay. Close. Now we put the infusion. Open it, please. Yes. Okay. The lens. Now the trick here is when you try to implant the lens, you want to implant the lens into the anterior chamber and not into the posterior chamber because you have no capsular support. And you always need to keep the trailing haptic outside the eye just to make sure it's not going into the wrong direction. Simple Sinskey hook or a second instrument to make sure that the haptic is above in the anterior chamber. Sometimes the infusion itself makes it difficult to see the haptic or to orient the haptic. That's why if I don't need it, I don't use it. Okay. Yes. Now I can see the haptic next to the infusion. We start to hold the needle into view, and we go from the paracentesis.
What's this instrument you are using?
It's a forceps by Romix. Try to hold it, and then start the insertion of the haptic inside the needle.
How many millimeters inside the needle?
From my experience, the more the better. Because this makes the lens orientation easy for the introduction of the second haptic towards the needle or towards the mouth of the needle. First haptic is already in place, then we hold the second haptic by the same forceps. This is the tricky part because you have to use the other hand. You have to go inside and then start the introduction of the second haptic inside the
So actually
needle.
the first haptic now it's outside? Or still in the tunnel?
The first haptic
the
is?
First haptic now. Still in the tunnel. Yeah, but...
The first haptic is already in the needle.
The needle is still inside.
It's not inside enough yet. I need to put it more inside. You notice it's a bit kinked now. You have to take care not to break it because sometimes it does break. Can we close the infusion, please? Maybe I have to switch my hands. It's easier to use the other hand. It's okay for now. Can you open the infusion? Okay. We'll try to retrieve the haptics now. We'll try with the trailing haptic first. We do it very slowly. We should be doing both at the same time, but one appears earlier than the other.
Actually, your assistant is holding
whenever
the
it
other
appears,
needle. There's an assistant who's holding the other needle, yeah?
No, I am holding both needles now, taking them out of the eye, very slowly, and as soon as I see the haptic, I stop. I hold the McPherson. And I grab it outside slowly. Now the assistant has to hold it because it can go back. ممكن تمسكيه لهناك ده.
What's the advantage in this technique rather than doing two scleral flaps and
leave. Sorry?
Just I'm asking
why don't you use the scleral flap and suture under the scleral flap?
I think
the advantage of the Yamani technique.
I think this technique, now we have both haptics outside. I think this technique, when you learn it and when it's in practicing hands, it's a quick technique that allows quick rehabilitation of the lens rather than opening the conjunctiva, doing the flaps and all those stuff.
I think that sutures break after a few years.
Yes.
If you are using Prolene.
Now, what we do here is we do a 1 millimeter on the caliber, just to mark up to where we're going to use the dithermy. Okay, so just a small mark on the haptic itself, just to mark where we're going to use the dithermy on both sides. It's never exact, but then with a handheld dithermy, we hold the haptic and we apply the heat and we see the bulb forming as you see here. It's like the head of the nail, exactly.
Sometimes you cut the haptic, part of the haptic?
Sometimes, but if it's too big. But here, as you can see, there's not a lot of haptic outside. We do the other part. I'm trying to zoom in to show you. Okay, yep. You see the formation. Is it clear now how it's like a bulb or a terminal bulb at the end?
You have a nicely centralized intraocular lens.
Yes, and then with the use of the McPherson, we just reposition those haptics into the tunnels again, but not just to make sure the haptics are under the conjunctiva. I'd like to push them inside the tunnel for a bit, because it is much more safer and they can't come out. So this is one inside, one haptic in, and then the other one in as well. Here we have the lens. Notice the lens is centered, but because we have a defect in the iris here, this is why we can see it's a bit, we feel it's a bit shifted, but now it is a centered, very well centered lens.
Would you consider bringing the pupil down?
I am. I'm ready. I'll just pop in one suture from the part where we've put the infusion. I'll just remove the infusion now. Put some viscoelastic into the anterior chamber to help me.
Myostat can do it, or?
Sorry?
Myocol?
Yeah, we're going to put myocol now to make the pupil smaller and see how it will look and decide if we're going to use any sutures or no.
Dr. Rami, I would like to congratulate you for this case. Dr. Rami, can you hear me? Dr. Rami?
Yes, Dr. Khaled, I can hear you very well.
Yes, I would like to congratulate you for such case. It's very difficult and challenging, and to do such case in live surgery, it really needs very good coronaries, because we can anticipate any troubles during such procedure. At any moment, you may fail to feed the haptic inside the needle, and you may have a broken haptic, and at this moment, you may abort the procedure completely, or you have to change the IOL. So that I congratulate you for your heart and your brave heart to do such case in live surgery. Thank you.
Actually, after the myocol, if you can see, Dr. Khaled, after the myocol, the pupil is small. I don't think we need pupilloplasty. We don't need to add something for the patient that he won't benefit for. I think this is enough. And I've learned that the least manipulation you can do to the patient is the best you can do, not the surgeon's ego, to make the pupil perfectly round. I think at this point, I can conclude the surgery, and I'm happy. And the patient is going to have a good quality of vision.
Wonderful surgery, Rami, really good. And we are shifting to Dr. Fathi, Dr. Maged Mikhail.
Thank you, Abdallah. We're very well done, Rami. And now we back to our last part of the surgery with Dr. Maged. Dr. Maged, please go ahead.
This is the intraoperative OCT. As you see, there is a large, huge macular hole. This is the macular window lens. I stained by brilliant blue G. Usually, the direction of the beam is centripetal toward the macular hole itself. Okay. In all directions. I have to be in order to reach the edge of the macular hole. I try to widen the area of peel.
As you see, this is the flap of ILM. I have to reach to the edge of the macular hole. I release the traction all around the macular hole from the ILM, and then widen the area of peel as much as I can. As you see by OCT, this is the floating ILM which inverted before I place it on the aperture of the macular hole.
Magid, the picture is overexposed. Can you withdraw the light away from the retina? This is much better.
Yes. Yes, this is much better. Yes.
Yes.
Okay. We can see by OCT floating off the ILM. It is a fantastic image of the intraoperative OCT. Now I have to place this inverted ILM flap on the surface, not tucking to the floor of the ILM, to allow for proximity of the photoreceptors. But before inverted to the surface, I have to shave the excess layer of ILM. I have to lower the vacuum as well as the cutting rate.
Magid, I think you have to lower both the vacuum and the cutting rate.
Yes, lower.
Because
yes,
if you use a high cutting rate,
yes,
the flap will be pushed away from the cutter.
It will slough. Yes. My parameter is 100 vacuum and 1,500 cutting rate. And then I will start to invert the flap. Sometimes I use a bare fluorocarbon to stabilize inversion of the flap to avoid displacement during air fluid exchange.
Excellent surgery, Magid, but I think it is more controllable if you invert the flap under PFCL. So I prefer to inject few cc of PFCL.
Yes, I will inject now the PFC. Yes, I will do this now. I will try to get the OCT image. You can see closure of the macular hole with the flap. You can see the OCT image of the inverted flap. It is fantastic view. This is the macular window lens I usually prefer. And then I will shift to the regular wide field Zeiss recite to complete my surgery. Yes, I will repeat the inversion of the flap and increase the bubble of biopsy. Focus on it. Focus. It's okay. I repeat the inversion under a bubble of PFC in order to avoid displacement or re-eversion of the inverted flap on the macular hole. And then I will remove the vitreous base. I usually remove the vitreous base in all vitrectomy case, as I learned it from Dr. Hassan. I usually do vitreous base shaving manually by putting the chandelier into one of the trocars of the superior sclerotomy and do indentation by myself using a high cut rate with lower vacuum. Focus on focus. I usually do indentation by myself with the aid of chandelier. As well as I examine the far fundus periphery very well in order for detection of any missing tear or hole to deal with.
Magid, do you think that intraoperative OCT has added to the precision of this technique, of your technique or your surgery? Or what is the advantages of
it's very
of using the intraoperative OCT?
Yeah, it's very nice to. Yes, yes, I found that it is very helpful. It's fantastic to see the structural changes of outer retina during peeling of the ILM, as well as it is a sure sign for placement of the flap at the end of the surgery during air fluid exchange, which is very risky for displacement of the flap. It is very sure sign that the flap is in place.
Yes, but you can see that with your eyes, without the need for OCT. I mean, what is the
yes, sure.
What is the advantage of using OCT in such a case? I know that it has advantages in maybe in other cases, but I'm asking you about this particular case.
Yes, I think sometimes during ILM peeling without inversion of the flap, we can see in minute macular hole, we can see actually by OCT it closes. So I think it has a beneficial for minute macular also to see the structural changes during peeling of the ILM, including closure on a spot of the macular hole, which is smaller in size. And in such cases, I can cancel the inversion of the flap and satisfying with ILM peeling only, not inversion of the ILM. Okay, so I do. As you see, I depending mainly on the chandelier in doing indentation by myself. And examine the periphery as well as removal of the vitreous base.
Maggie, some surgeons believe that it is in macular hole surgery and also in epimacular and posterior pole surgery in general. Excision of the basal vitreous gel is not important. What do you think?
I think removal of the vitreous base is mandatory in almost all cases. To remove vitrectomy, as we know before, vitrectomy is done when vitreous is gone. We have to remove all vitreous fibrils as much as we can. Also, removal of the vitreous base allows us to see any missing tears during indentations also, so I have to examine the periphery as much as I can and remove the vitreous base as well. After indentation also during air fluid exchange, I can find any residual vitreous base as air act as help in finding the meniscus of the vitreous, any residual vitreous base. I have to remove it also during air fluid exchange.
بس احنا ماشيين زي الساعة.
Magid, are you satisfied with this area of ILM peeling? Wouldn't you like to enlarge the area of peeled ILM?
Yes, I usually enlarge it as much as I can. If I can remove more, I will. The larger peeling, the more relief of any exertional susceptible traction on the surface of the retina. Yes, I totally agree, of course. I usually remove the posterior capsule because it is usually opacified, and in the residual vitreous behind the lens also it will remove. This is the same parameter of the machine during removal of the tag of the eye lamp. I usually do posterior rexus at the end of my surgery. And then I will switch to air.
Okay, Dr. Hassan, I hope you are satisfied with the performance of your fellow, and you've done a good job.
I'm always satisfied with what Magid is doing, and he is really an excellent vitreous.
Thank you, Dr. Hassan. Thank you.
Thank you, Dr. Hassan. And now we have 15 minutes for discussion, whether with the four surgeons that have not been interviewed. Dr. Muhammad Abdel Hafiz for his blepharoplasty case, Dr. Rami for his Yamani technique, Dr. Ashraf Armeya for the white cataract, and Dr. Basim Faiz for the brown cataract, or any of the other surgeons. Please go ahead.
Rami, good afternoon and well done. And I'm Muhammad Hosni. This was a very, very elegant Yamani technique. Usually Yamani technique in the middle, there's a lot of intraocular gymnastics and acrobatics, but in this case it was very, very nice and very well demonstrated. So I congratulate you. And we all hope that at the end of the surgery that you have a more or less rounded pupil, not yani, to spend more time doing the pupilloplasty, and this is what happened. So are you comfortable using the Yamani technique all the time? Do you what lens do you use? What intraocular lens do you use?
It's the Sensor 3-piece lens. I have tried the MA lens as well, but I found that the Sensor is a more friendly lens to use this to use this technique. This is the only available 3-piece lens actually that we have now in Egypt to use this technique.
Yes, and what type of needle do you use to feed the haptic in? What gauge?
It's an insulin needle, a 27 gauge needle. But as I showed in the beginning, sometimes those needles are not very well manufactured, and this is why I need to try to put the haptic inside the needle before introduction to the eye, because I don't want to have the needle inside the eye and then have the haptic not going into the needle because of a manufacture problem.
Again, this was a very nice surgery, so I can congratulate you for this.
Thank you, Dr. Muhammad. Thank you very much.
Hello, Rami. This is Hassan Murtada Rami.
Hello.
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 Rami, excellent technique and really amazing surgery. But there is always a problem of lens tilt with scleral fixation IOLs. And do you have any solution for that? Because I think it may induce certain degree of astigmatism, or do you have any tricks to overcome
in the
this?
Beginning, yeah, in the beginning, Dr. Hassan, when I started the technique, I wasn't putting the marks that you've seen in the surgery. So sometimes we would have the two needles not 180 degrees apart exactly, and this would cause some tilt. And sometimes when you mark, the mark is a bit big, so one is 1.5 millimeter away from the limbus, the other one is like 2 millimeter away from the limbus. Then this also makes a tilt of the lens. But with the few last cases that I've done, when I make sure that the marks are exactly opposite each other and that the entry site is exactly 1.5 millimeter away from the limbus on both sides, I have no tilt.
Okay. Another question. I totally agree with you that the only lens that is suitable for this technique is the Sensor Bausch and Lomb lens because the C loop and the long C loops, and I think this is very stable lens. But may I ask you, instead of the needle, can we use forceps? And I know that there are a couple of forceps, curved forceps that can be used maybe easier to have the haptic outside, and instead of feeding the haptic into the needle, which I think is not easy, and also it may slip as you take it outside the eye. So can we use forceps to grasp the...
I am aware of this technique that they just introduce ab externo. They create the tunnel and then they introduce a very, very thin, I think 25 or 27 gauge forceps that goes inside intrascleral into the anterior chamber and grabs the very tip of the haptic and takes it out using, and then do the same technique. I agree. And also the concern, actually I'm doing the technique, but my concern is the needles that are going through the pars plana and that are kept there for a long time during the surgery, and like they might be hitting the vitreous, the base, the ora serrata, and you cannot see actually where they are going. So this, I think that if we have a forceps that can go through this tunnel and grasp the haptic, it's a much safer technique.
Okay, thank you, Rami. Excellent surgery.
May I add a comment here because of the tunnel? If you have a tunnel and introduce the forceps, whatever the forceps is, 25 or 27 gauge forceps, this tunnel made by the forceps definitely will be wide around the haptics of the IOL. So even if you did a knob by the thermal cautery, this knob will slip through the canal and into the posterior segment of the eye. This is the main concept of the Yamani technique, that we need a scleral tunnel just tight enough to hold the haptics of the sensor lens to prevent slippage, and we can add safety by making the knob. But if we made a tunnel, this is the Chariot method that has already been published in 2007 or 2008, and we have to find a way to tuck the haptics into a scleral canal or under the flap like Amara Grawal. This is, I think, why we cannot use the forceps in this case.
Can I have a question about the
Any
Zen
other
implant?
questions to the different colors of cataract?
About the Zen implant, can I have...
Yes, Dr. Ahmed Yusri.
Yes, what's the question? Sorry.
Yeah, how are you, doctor? You showed us today a different way of Zen implant surgery. You actually you showed us the ab externo technique. So actually, such implants has been created to be less traumatized, or to do less trauma to the conjunctiva. So your approach is a little bit different. So I don't know how can you be less traumatized to the conjunctiva, or how with this needle is big actually. So I don't know how you can explain to us this technique. For which reason, yes, you approach it
the main aim. Okay, the main aim of this procedure is to not to prejudice the conj. I'm not dissecting the conj by scissor and cut like in focus, for example. I'm just injecting the stent under the conj, which is really not traumatizing at all, because you do that when you do the needling on the slit lamp. You just move the needle under the conj. This is not much of traumatizing of the conj. So the conj is just under the level of the conj that then is injected. This is not much trauma at all. This is just even as you do the injection of the 5FU or the MMC, because your MMC sometimes you can inject it subtenon during the TRAVI operation before you open. So this is not considered traumatizing at all.
Actually, your technique looks much more easier.
And actually, it has more benefit.
It's much, and looks much
It's
more
easier, that's one.
Than the, yes.
Other benefit. Second, it is definitely under the conj. Third, you can do temporal one if the nasal doesn't work. Third, if the high bone cheek or the cheekbone is high and you cannot really, because of the angulation of your arm, you cannot go into the subtenon space from the temporal side, you can do one easier from the top. And lastly, if you are very busy, I think in the future we can try it at the slit lamp in the clinic. Who knows?
And you have to suture the entrance point? You have to put suture at the end?
No, no suturing. No suturing at all. No suturing at all. The conge entry is just very, very small. And the needle is not that, it's 25 gauge, which I use probably, or 27. It's what I usually use when I do the needling on the slit lamp. So, or you do the needling when you go take the patient to the operating theater. So you can do the needling without any suture. Remember, the tenon is a sponge. One, it is swollen by the fluid, whatever injection you are doing, it will just block it. And again, the track doesn't follow the same track anyway.
Okay, thank you.
Pleasure.
Question for Dr. Mohammed Al-Hafid for the blepharoplasty. Dr. Mohammed, thank you very much. Very nice operation. I noticed that you did meticulous cautery of the wound edge all over in both eyelids to maintain totally blood-free view. Is that your technique? You like make sure there is no blood at all? Is that how you approach this cauterization of the wound and that I saw?
Thank you, Khalid. Yes, this is my technique in all cases. I prefer not to leave the edges of the wound oozing because this will cause the post-operative hematoma. This will cause the post-operative hematoma, which is something happens in many cases after blepharoplasty, and this is the worst thing you can have. It's the patient will be very happy when you achieve a bloodless field and no hematoma post-operatively. And I'm not afraid of delayed healing because, as I said during the surgery, that the lid is very vascular. As we all know, it has a double blood supply. And we are not afraid of delayed healing from the cauterization. But I don't do this excessively.
Yeah. In that case, like your post-op care, what is your post-op care in those current patients? What is your regimen for post-op care?
Post-operative care, I don't... The most important thing in the post-operative care is the ice compresses. I ask the patient to do ice compresses every 2 hours except during sleeping. So it will be around 5 or 6 times a day. I give them a mask and they keep the mask in the fridge for a couple of hours. Then they put it over the eye for around 15 minutes and then back to the fridge. And they should be relieved from the ice for a couple of hours between each time. So it will be around 5 to 6 times. I don't give systemic antibiotics. I'm not afraid of any infection post-operatively, but I give topical soothing eye drops because the blinking mechanism of the upper lid will be a little bit defective after operation. So I would rather prefer giving them lubricants to protect the eye from dryness, especially by night.
Thank you very much, doctor. Thank you.
Thank you, Khalid.
Still have time. Dr. Ashraf, really excellent phaco, but sometimes the spiral rexus produces eccentric anterior capsulotomy. Have you encountered this complication? So some of the capsule appear in the pupil, and how can you avoid this?
Yes, the most important when you start a spiral rexus, you start spiral rexus in the center of the rexus, of the anterior capsule, not periphery. And when you enlarge it, you track your enlargement in the same way as it's circular, like you are enlarging your rexus. And always keep the rexus, the anterior rexus, which you removed inside the center not make it away from your track. Because if you make it away from your track during the rhexis will going to extend, and you are going to avoid this by enlarging. So you are not going to be central at this point. So if you, from the start, you start your spiral rhexis from the center of the capsule and enlarging in the same way from 6 to 12, and you concentrating that you are in the center, every time you are enlarging your rhexis, you are going to keep your rhexis always central, not eccentric. Always, but never leave your the spiral part of the rhexis to go away radial. At this point, you may lose your centration of the urorhexis.
Thank you, Dr. Ashraf.
And always keep your anterior chamber deep.
Okay. Do you care of polishing the anterior capsule? Because I noticed you polishing the posterior capsule, which is a very good habit, especially in myopic patients. But some of these cortical material, you may have got them if you start at the equator. If you start irrigation aspirating at the equator, you may have some of these cortical material because they have continuation to the equator. And also polishing of the anterior capsule. Can you tell us your parameters for polishing the anterior capsule?
Yes, usually I do the polishing, start from the edge of the rhexis to the equator of the lens, because in these long-standing white cataracts, you always leave some cells in the equator of the lens. So you always do this.
If I have a last comment on polishing the anterior capsule, I think getting older, we've noticed that the lenses that have capsular phimosis would tend actually to displace, including the whole back. So maybe the traction that goes onto the anterior capsule actually start breaking the zonules and the lens will eventually prolapse. I think we've come to the end of our session.
Yes.
And I would love to thank the committee for inviting us to broadcast the live surgery, and would thank the panel.
And thank you so much, and thank you for all the crew. It was excellent surgeries and excellent talents.
The moderators. Thank you very much, and happy Valentine. And now we can start celebrating the day.
Okay.
Thank you very much, and we thank Dr. Saleh for inviting us. Enjoy the rest of the meeting.
So this session is concluded. Okay. Now we now have the award for the best attendance, right? So we are going to broadcast now the video of the day, and then after this, the award for the best attendance.